अगर बीच में शेयर हुई थी अपनी,
हाँ
बीच में शेयर हुई थी अपनी।
अस्सलाम वालेकुम।
मैडम एक मिनट चले बोले।
Assalamu alaikum. Welcome to the review course of Silver Jubilee of Pakistan Society for Rheumatology. We will be shortly starting at 1:30 p.m. our time the review course. Thank you for joining in, and if you would like to grab a coffee or a tea, please go ahead, and we will start at 1:30 p.m. sharp. Bismillahirrahmanirrahim. Rabbi zidni ilma. My Lord, increase me in my knowledge. Assalamu alaikum, ni hao, konnichiwa, hello and welcome to the Silver Jubilee of the Pakistan Society for Rheumatology Annual International Conference. I'm Dr. Saira Khan, your host, and I'm joined by Dr. Bilal Azim Bhatt, my co-host for this event. We are both humbled to have been given the opportunity for convening this conference. Starting from a very humble beginning in 1995, when a handful of rheumatologists had returned from the UK and USA, this society was formed. We have indeed come a long way today and are now celebrating the Silver Jubilee of this annual international conference. I welcome all of you to the Rheumatology Review course. The course faculty is comprising of the most prestigious and respectful people in the world of rheumatology today. We are indebted to them for their generosity in sharing their time and expertise with us. We could not have done all of this without the support and guidance of our patron, Professor Nigat Mir Ahmed, who is one of the pioneers of rheumatology in Pakistan. We are further indebted to Professor Sumaira Farman Raja and Professor Dr. Ahmed Said, without whose support we could not have managed any of this event to take place. The chair of the session of the Rheumatology Review course is Professor Sumaira Farman Raja. She is the head of Department of Rheumatology in National Hospital and head of pediatric program at the Institute of Rheumatic Diseases in Central Park Medical College. She is co-founder and co-trustee of Arthritis Care Foundation. But for us, both me and Bilal, she is our supervisor and we are her trainees. I am humbled to ask Professor Sumaira Farman Raja to say a few words before we begin.
Saira, thank you so much. Assalamu alaikum and good day to all of you. It is such a pleasure to welcome you on behalf of the scientific committee and an absolute honor and privilege to welcome our luminary speakers. We have an absolute all-star cast today, and thank you so much for giving us the benefit of your knowledge and time. So I would like to move on to introducing the first talk and speaker. This is by Professor Laishan Tan. She has been a dynamic leader within Asia Pacific region and as part of AFLAR. She is presently convener of the AFLAR Academy and also AFLAR International Affairs Committee. She heads the Division of Rheumatology.
For your kind words. Thank you, Dr. Sumaira. I will be handing over the control of this session to Dr. Bilal Azim Bhatt from now onwards. Thank you.
Bismillahirrahmanirrahim. Thank you and welcome to the first session of the Rheumatology Review course of Silver Jubilee Pakistan Society for Rheumatology Conference. The first session will have 5 talks, and after the 5 talks we'll have a live Q&A session where you can question and answer from the speakers of the first session. After the Q&A we'll have panel discussion. You can post your questions in the Q&A section of the Zoom and then they will be answered. I want to stress that at the end of this session, you will be given a link where you can fill in the feedback form in order to claim your CME credits and in order to get your certificates. Now let's start with the first talk.
My name is Laishan Tan. I'm a rheumatologist from the Chinese University of Hong Kong. It's a great pleasure for me to be here joining this important Pakistan Society of Rheumatology Annual International Conference. I would like to thank Professor Farman and the organizing committee for the kind invitation. It's a pity that I can't join you in person, but I hope to see you soon in December during the APLA meeting. So today, my topic is towards precision therapy and reversing bone damage in inflammatory arthropathies. So in the interest of time, I'm going to mainly focus on psoriatic arthritis. Here are my disclosures. So we will first discuss the unmet needs in managing patients with psoriatic arthritis, and then we will talk about how to identify PSA patients with poor prognosis as measured by structural damage, and then we will talk about identification of PSA patients who will respond to treatment, followed by a novel assessment tool for bone damage in RA and PSA to address the unmet needs, followed by a summary. So I'm sure all of us are very familiar with the pathogenesis of synovitis in rheumatoid arthritis, and for patients with spondyloarthritis, such as psoriatic arthritis, the main pathogenesis is actually enthesitis, and then secondary synovitis. Now, the different phenotypes occur as a result of genetic predisposition, environmental triggers such as mechanical or metabolic causes, infections, and all these factors also affect the local innate cells, for example, in the skin's epithelium or the gastrointestinal tract, and ultimately leading to the expansion of Th1 cells as well as the Th17 cells, expanded by IL-23 and IL-12, resulting in increasing production of TNF-alpha and IL-17. So in those genetically predisposed individuals for peripheral synovitis, these are mainly Th1 cell driven, and these patients usually respond to TNF inhibition. And for patients with the anthesial predominant pattern with or without axial disease, they involve both Th1 cells as well as Th17 cells. So they respond to both IL-17 and TNF inhibition. Now, it's very important to understand this because we now have so many, drugs that we can choose from, okay? However, you can clearly see that at least 40% of patients do not respond to, either one of these treatment. And despite having so many choices, drug trials have demonstrated that radiographic damage develop in 5 to 15% over a year and 30 to 40% after 3 years of biological DMARDs. And then patients with radiographic damage have poor function and disability, increased healthcare utilization, work disability, and increase in unemployment. So that's why it's very important to identify these patients who are at risk of developing bone damage. Unfortunately, currently we are still using radiographic assessment as our gold standard, but these are not sensitive in picking up early disease. So what are the clinical predictors of poor outcome? So clinical predictors include a delay at least 6 months or a year, older age, female sex, smokers, history of TNF use, dactylitis, high acute phase protein at diagnosis or during the course, polyarticular disease at presentation, and nail psoriasis. Unfortunately, these parameters are not adequately validated and are not considered to be sufficiently discriminatory used in clinical practice. Now, how about genetic markers? So there are a number of studies. The first one from Canada, they found HLA-B27 in the presence of HLA-DR7 and HLA-DQW3 in the absence of HLA-B27 predicted increase in damaged joints. Whereas in UK, they have identified HLA-CW6 and HLA-DRB107 haplotypes was actually associated with less damaged joints, although these two, haplotype were not independently associated with disease severity. And the latter finding was replicated from an individual cohort. The other parameters which can predict development of erosions include polymorphism of IL-23 receptor, HLA-C 010201 allele, HLA-B27 0502, and HLA-C 010201 haplotype, IL-4 receptor gene variant, and also gene coding both TNF and lymphotoxin alpha. So before we talk about other, soluble biomarkers, let's take a look at the bone remodeling pathways in psoriatic arthritis. So we've mentioned antigen-presenting cell release IL-23, which expand Th7 in cells, and also release IL-12 to expand the CD4 positive T cells. And then these cells subsequently can increase the expression of rank ligand, and the cytokines can also activate the fibroblast fibroblast-like synovial okay? And these cells can lead to increase in rank ligand expression, and together with activation of mesenchymal stem cell producing MCSF, this would lead to differentiation and activation of osteoclasts and leading to bone loss. On the other hand, the role of IL-17 and TNF-alpha in the osteoblastogenesis pathway is less clear. Both these two cytokines can inhibit the Wnt ligand pathway, leading to a decrease in osteocytogenesis. But IL-22 can actually stimulate IL-17, leading to activation of mesenchymal stem cell and the osteoblast differentiation. And in addition, the pro-inflammatory cytokine can also activate the metalloproteinases, as well as the ADAMS expression, leading to degradation of extracellular matrix, and then bone and cartilage degradation, resulting in erosion and joint space narrowing. So on the other hand, osteoprotein secreted by osteoblasts can lead and inhibit the rank ligand binding to rank and decrease osteoclastogenesis, whereas DKK1 and sclerostin can inhibit the Wnt signaling pathway, resulting in inhibition of bone formation. Now, after understanding all these, I'm sure all of us will be interested to see whether any of these biomarkers can predict radiographic damage or are associated with radiographic damage in PSA. And the answer is quite controversial. So, for example, osteoprotein, MMP3, rank ligand, MCSF, and DKK1 have all been studied in cross-sectional studies, and the association was quite controversial. And then for the collagen-related proteins, so in the cross-sectional study, again, is not, quite definitive. But in the longitudinal study, serum type 2 collagen was found to be associated with radiographic progression after 1 year. And then acute phase reactants, including calprotectin, serum amyloid A protein, the S100A12 protein, and increase in CRP level have all been associated with radiographic damage. But again, it is still a bit controversial. Now, how about biomarkers predictive of treatment response? So currently, most of us are still using a trial and error approach. So GRAPPA has advised this domain-based approach. So and based on the previous pathobiology, we are quite familiar with the choice of drugs inhibiting the IL-23 or 17 pathways if patients present with predominantly skin disease, whereas we tend to use TNF inhibition for patients who have a predominant peripheral joint manifestations. But then still we want to have a bit more guidance on which drug to give our patients, right? So we want to have a more precise approach. So do we have any biomarkers which can help us? And the answer is yes. Like genetic biomarkers have been studied in terms of response to TNF inhibition. So polymorphism in TNF A1, AIP3, TNF 308 A allele, and the IL-6 174GG homozygous genotype, as well as the TNF 489 allele. All these genetic biomarkers were associated with good response to TNF inhibition. And then there are also TNF biomarkers, tissue markers, which can indicate a good response. So there are 3 studies which have used a synovial tissue analysis to evaluate treatment response. In one study, changes in CD3 expression in the synovial sublining layer following treatment with anakinra and etanercept were greater response than in non-responders. And then there's a second study using proteomic analysis of the synovial tissue samples following anti-TNF treatment, identified 25 proteins that were differentially expressed between good responders and poor responders. And a third study using the targeted proteomic strategy screened 57 proteins in synovial tissue samples. And then they have a combined predicted treatment, which was having a modest area under the curve of 0.76. Apart from that, tissue markers are difficult to get, so we would, prefer serum biomarkers. And the majority of the result indicated CRP was associated with a higher CRP level was associated with a better response, whereas IL-6 level was a bit controversial. And other studies have also looked at a combination of biomarkers, which was also found to be useful. But I guess these studies need to have further validation before we can use it in the clinical setting. Now, there's actually one pilot study utilizing precision medicine in guiding therapy. So this is a pilot study from Professor Yoshia Tanaka's group. They have use phenotyped the peripheral T helper cells using flow cytometry, and then classify patients into 4 phenotypes, including a Th1 cell predominant, Th17 cell predominant, Th1 and Th17 high, Th1 and Th17 low, and then these patients were characterized afterwards, were as selected to use ustekinumab and secukinumab for predominant skin manifestation, or TNF inhibitor for predominant joint inhibition, and a TNF inhibitor. So different cell types use different therapies according to the subtype. So after 6 months, the 26 patients in the strategic treatment group was associated with better response compared to the standard treatment group in terms of achieving SI-LDA, DAS, ESR-LDA, as well as ACR20 responses. So although this is only a small study and the patients are not randomized, it shows that personalized therapy according to immunophenotype may be feasible. So we are eagerly looking forward to larger studies to confirm the results. So so much so for the the current progress in the precision medicine. There are also other large-scale multi-center studies going on, looking at the multi-omics, also large registry database, and so these results we are eagerly awaiting. So meanwhile, I would like to introduce to you a new biomarker, imaging biomarker, which probably can enhance us to understand a bit more, to see who are the patients at risk of developing bone damage, and to see which therapy is useful for preventing bone damage in these patients. Now, I've mentioned earlier on, currently we are still using radiography as the gold standard. However, in radiography, of course, we can look at soft tissue swelling, periarticular osteopenia, joint space narrowing, as well as erosion and new bone formation. But radiography is not sensitive in picking up patients with early disease. So for example, this is a patient with early RA, and you can hardly see any erosions. So you can consider doing MRI, but sometimes it's not good enough for picking up bone damage. So nowadays we're using a high resolution peripheral quantitative computer tomography, or HRPQ-CT. So it's a small machine, and you can put in the hands or the feet, and in the Extreme CT2, the newer version, we can also put in the ankle as well as the knee. And this HRPQ-CT is a dedicated extremity imaging system designed for trabecular scale imaging with very high signal to noise ratio and a very high spatial resolution compared to other CT or MRI, with isotropic voxel size of 60 to 82 micron, and low radiation, 3D character, and quantitative in nature. So it's very useful for pathophysiology or bone structure study, and we can also use this to define structure protecting effect of anti-rheumatic therapy, which I'm going to show you in just a second. And it has higher sensitivity in detecting erosions compared to radiograph and MRI. So these on the upper panel B and C, you can see the 3D reconstruction image of the MCP joint. And on the lower panel D and E, you can see the 2D images. And on panel A, you can see we can actually use segmentation to look at the cortical bone versus the trabecular bone, and the erosions are all highlighted in green, which is very easy to see. Now, we can use this technology to, identify, who are the patient who is going to develop PSA versus RA by looking at the shape of the erosion. So U-shaped erosions can be typically found in patients with rheumatoid arthritis as well as in psoriatic arthritis, but the omega shape erosion in the middle panel typically is observed in patients with psoriatic arthritis, whereas the T-shaped erosion in the lower panel typically represent vascular channels. And in patients with psoriasis without psoriatic arthritis, you can see that actually new bone formation and enthesopathy highlighted in the lower panel, as indicated by the red arrows, are a typical feature of patients with psoriatic disease, which is rarely seen in healthy individuals, whereas erosions may be seen in both psoriasis patients as well as in healthy controls. So bone erosions in psoriatic arthritis are age-dependent, enhanced in PSA, and increased with disease duration. However, enthesiophytes are less age-dependent, are enhanced in psoriasis and psoriatic arthritis, and is strongly influenced by disease duration. So it's a more characteristic feature in patients with psoriatic arthritis. More importantly, it is associated with physical dysfunction, and therefore early therapeutic intervention to prevent enthesiophyte progression should be considered. Now, this machine is also very precise, and using registration technique, we can follow our patients prospectively after treatment and see what happens. So these are rheumatoid arthritis patients, and you can see after treatment with TNF inhibitors, the width of the erosion wasn't changed, but the depth of the erosion was decreased, comparing the left-hand panel and the right-hand panel. So there is evidence of healing of erosions. Now, looking at patients who receive tocilizumab, you can also see a decrease in width and depth in those patients who respond to this kind of treatment. So if we compare tocilizumab monotherapy with methotrexate and adalimumab therapy, we can actually see better erosion healing in patients who receive tocilizumab compared to adalimumab and methotrexate, suggesting that in patients with rheumatoid arthritis, probably inhibition of the IL-6 pathways plays a more important role in erosion healing. Now, in patients, we've also talked about rank ligand being the major pathway for osteoclast differentiation and activation, resulting in erosion progression. So we have also conducted a randomized placebo-controlled study in patients with rheumatoid arthritis, and after 2 years, you can see on the panel A, the proportion of patients achieving erosion healing was significantly increased compared with the placebo arm, and the number of new erosions detected or erosion progression was also significantly higher in the placebo arm compared to the denosumab arm, and denosumab was associated with threefold increase in erosion healing after adjusting for other risk factors, suggesting that using this sensitive imaging technique, we can observe that targeting the rank ligand pathway alone is effective in improving erosion healing without affecting the inflammatory pathway. Now, how about patients with psoriatic arthritis? So we've talked about new bone formation, and new bone formation is not routinely assessed using radiographic scores, but it can be easily seen and monitored using HRPQCT as indicated on the image on the right-hand side. So the arrows indicate new bone formation, what we call enthesiophytes, and we can monitor the progression very clearly using HRPQCT. And in this study, you can see after treatment with methotrexate or anti-TNF, although erosion progression was inhibited, but new bone formation continued to progress in patients treated with TNF inhibitors as well as methotrexate. Now, in contrast, patients treated with IL-17A inhibitors demonstrated rest of erosion progression as well as enthesiophyte progression, as well as resolution of synovitis on MRI. So apparently, inhibition of IL-17 pathway may play a more important role in preventing bone damage in patients with or new bone formation in patients with psoriatic arthritis. And we have also looked at our PSA patients. So after a period of 5 years, these patients are treated with conventional synthetic DMARDs as well as TNF inhibitors. And you can see actually 1/3 of them had erosion progression on the left-hand side. And actually, more importantly, half of them demonstrated progression of new bones despite treatment. And on the right-hand column, you can see those who were treated with a TNF inhibitor actually did not have significant improvement in terms of the bone damage, but patients who have who can achieve treatment target in terms of DAPSA low disease activity at baseline as well as in 5 years have a significant less progression in terms of erosion as well as the size of enthesiophyte increase. So suggesting that it's very important for us to control disease activity in order to prevent bone damage. So in summary, ladies and gentlemen, I have discussed with you the unmet need for predictors of poor outcome and response to treatment in patients with psoriatic arthritis. And I have also emphasized that early identification of patients with a poor prognosis, which will enable the application of precision medicine in order to prevent disease progression and irreversible damage. And nowadays, using HRPQCT, repair of erosion and prevention of new bone formation can be clearly demonstrated in RA and PSA patients after effective immunosuppression. Now, in the future, advanced imaging modality and tissue analysis, as well as multi-omic approaches, will need to be employed to improve patient outcomes. So I would like to thank all of you for your attention, and I look forward to your questions and comments, and I also hope I will see you all in Hong Kong in December for the APLA 2022 Congress. Thank you very much.
Thank you so much, Professor Tam, for such an enlightening talk, especially about the utility of HRPQCT in the diagnosis and the treatment. Now we move on to our next talk. The next talk is by Professor David Eisenberg. He is the Emeritus Professor of Rheumatology at University College of London, and he would be speaking on year in review of lupus and APLS.
Many thanks for this kind invitation to talk to colleagues in Pakistan on a subject very close to my heart, lupus and antiphospholipid antibody syndrome. Where are we now? I think of lupus as a clinical syndrome. Its cause clearly remains unknown, although it's a family within a family of autoimmune rheumatic diseases, which includes lupus, the Sjogren syndrome, myositis, scleroderma. It's clearly mainly a disease of women aged between 15 and 50. And certainly in the UK, it's approximately 5 times as common in the Black community as it is in the white community, with the Southeast Asian community somewhere in the middle. And its clinical diversity is clearly matched by its serological diversity. Since 1978, in the group of patients that I'm associated with at University College in London, we've looked after 820 patients long term, but 14% of these patients have died. The numbers of patients in the group and the sex ratio is reflected in other groups. So approximately 10 times as many women as men get lupus. At the time we looked at this figure a few years ago, the duration of disease was 14 years. It's probably slightly longer now. But you can see the ethnic mix with Caucasians having the majority, 56%, the Black Afro-Caribbean community, 22%, Southeast Asian community, about 13%. And we're quite close to Chinatown in London. So we have about 5% of our patients are actually Chinese and a number of mixed ethnicities. In terms of the clinical features that we see in these patients, I and my colleagues are essentially rheumatologists, so 90% of our patients have arthritis, which is not surprising. The majority have a rash. Many of those rashes are photosensitive. About a quarter of patients have marked alopecia with recurrent crops of mouth ulcers, and about a third of the patients have serositis. Biopsy-proven renal disease we have in about 30% of our patients, a major CNS involvement, psychosis, and seizures in about 20%. Serologically, virtually all of these patients have a strongly positive anti-nuclear antibody. Many of these patients also have antibodies to the so-called extractable nuclear antigens, anti-SM, RMP, Rho, and LAR. About 2/3 of our patients have antibodies to DNA, and about 25 to 35% of the patients have anti-phospholipid antibodies. Coombs positivity is recorded in about a quarter of these patients, and about 12.5% have antithyroid antibodies. And just to add to the mix, about 45% have a low C3. In terms of what causes the death, or what has caused the death of these patients, infection remains the king, unfortunately, at 33 out of 116 patients. Cancer, fairly ubiquitous amongst all human populations, is second, with atherosclerosis known to be increased in lupus patients, third in 22% of the patients. Now, I want to emphasize that patients with lupus, once you've made the diagnosis, you can't sit back on your laurels and say, oh, I've made a diagnosis of lupus, I can relax now, because unfortunately, about a third of lupus patients have a second, third, or even fourth autoimmune disease. The commonest are Sjogren syndrome and the anti-phospholipid antibody syndrome. Hypothyroidism is present in about 10%, and rheumatoid arthritis, diabetes, and ulcerative colitis between 2.5% and 5%, with hypothyroidism and myasthenia gravis in about 1% to 2% of the patients. Now, let me focus on the phospholipid antibody syndrome. Clearly, there are two major components: thrombosis, which can occur in a wide variety of sites, can be venous or cerebral, and can give rise to these very nasty ulcers, as you can see here on this patient's leg. Obstetric mobility is also very striking. This is defined as being present where there are more than 3 miscarriages occurring at less than 10 weeks of gestation, more than 1 fetal death, 1 or more than 10 weeks, premature delivery associated with preeclampsia and placental insufficiency, and of course the presence of the persistent anti-phospholipid antibodies. Now, the laboratory of diagnosis of anti-phospholipid antibody rests upon distinguishing the presence of a lupus anticoagulant, a very bad name for it, obviously, because it's not confined to lupus patients, and of course it's not an anticoagulant, it's actually a really don't know. Antibodies to cardiolipin and antibodies to the cofactor beta-2 GPI are present in many of these patients, as shown here. You have to test for both IgG and IgM antibodies. And there are also, for the cognoscenti, if you like, the non-criteria anti-phospholipid antibodies, antibodies to phosphatidylserine, antibodies to TFPI, and anti-annexin. Now, there's a range of a spectrum of thrombotic events in these patients. There are patients who have the antibodies but no thrombotic events. There are patients who have the antibodies and a minor deep venous thrombosis, those who have severe thrombosis, those who have anticoagulant refractory thrombotic APS, and fortunately very rare, the catastrophic antiphospholipid antibody syndrome occurring in about 1% of APS patients. Now, there has been some exciting developments, and that's really where this talk is going to focus on today, in terms of anticoagulation. And the key question to ask is, anticoagulation, does it work? And of course, is it safe? Now, I thought I'd tell you a little bit about the history of this because it's kind of interesting. In the 1920s, healthy cattle in the United States began to die of internal bleeding. And these deaths were linked by farmers to the damp, moldy sweet clover hay that was being given to their cattle because they were trying to cut their feeding costs. A veterinarian, Roderick, proposed in 1929 that the acquired coagulation disorder was in fact due to a plasma prothrombosis defect. And then a remarkable part of this story, a farmer from Wisconsin known as Ed Carlson drove 200 miles in a blizzard, so it is recorded, to deliver a dead cow to an agricultural station where he met a guy called Carl Link and his student who began experiments using blood from this cow. After 6 years of work, they managed to crystallize a dihydrocoumarin, and they showed that this natural coumarin is oxidized in moldy hay to form the dicoumarin. And the larger scale production of dicoumarin was done by Starman, working at the Wisconsin Alumni Research Foundation Institute, or WARF, so you can see where the name warfarin was going to come from. But it was Link who first proposed that it could be used as a rat poison. And he developed 150 variations of naturally occurring coumarin. Number 2 was the most active, and thus warfarin was born. And it acquired a certain notoriety in a good way, in that a United States president, President Eisenhower, was given warfarin after a myocardial infarct over 60 years ago. There were many problems working out how best to establish the therapeutic target range before the WHO introduced the so-called Internationalized Normalized Ratio, or INR, 40 years ago. And here's Carl Link showing his rat poison. And warfarin has been a mainstay of anticoagulation for many, many years. But the primacy of warfarin has been challenged recently by the use of the direct oral anticoagulants, or DOACs. But let's look at warfarin in terms of what I call the good, the bad, and the ugly. It's a very effective way to treat blood clots in the legs and the lungs. It reduces the risk of stroke in atrial fibrillation. It's protective for those with mechanical heart valves. The bad is that there are food restrictions. You have to be very careful about not eating too much kale, spinach, Brussels sprouts, parsley, red cabbage, green tea, and avocados. And you also have to avoid certain drugs if you're taking warfarin. This obviously includes aspirin, the non-steroidal anti-inflammatory drugs, but also antifungals and a number of antibiotics and Tylenol. And of course, from the patient's point of view, in terms of quality of life issues, it requires a regular blood test, often done weekly. And of course, for some patients, unfortunately, where the INR is hard to control, it can cause some superficial bruising, but more seriously, gum bleeding, menorrhagia, and most worryingly of all, intracranial bleeding. So this is a problem. So it was very interesting when the direct oral anticoagulants, the DOACs, began to be developed over the course of the last 15 years or so. There are 2 forms, the so-called direct thrombotic inhibitors, that's dabigatran, and the factor Xa inhibitors, apixaban, edoxaban, and rivaroxaban. And as this slide indicates, there are marked differences in terms of bioavailability, in terms of time to peak concentration. The half-life is somewhat variable, and the standard therapeutic dosing ranges quite widely and quite differently according to the different drugs. This is just a pictorial way to show the difference between dabigatran, which is seen over here, blocking factor 2A here, apixaban, edoxaban, and rivaroxaban, which block factor 10A. So the history of anticoagulation goes like this. Unfractionated heparin developed in the 40s. In the 40s and 50s, we have warfarin. Then we get the low molecular weight heparins. And finally, we get through to the fondaparinux, then dabigatran, rivaroxaban, apixaban, very, very widely used, coming in about 10 years ago. Now, the advantages of a DOAC is that they are oral administered at fixed doses. They do not require regular anticoagulant. And they're at least as effective as the vitamin K antagonists, such as warfarin, for the prevention of the treatment of venous thromboembolism and atrial fibrillation. And there is no interaction with food or alcohol, and fewer interactions than warfarin with other drugs. So from the patient's point of view, this is really quite good in terms of standard of life issues. And in particular, it doesn't require regular blood tests to be done, which is good. They've been used very widely for probably millions of patients around the world now for non-valvular atrial fibrillation, for venous thromboembolism in terms of treatment, but also in terms of prevention. Now, my colleague, Professor Hannah Cohen, and I were sufficiently impressed by the use of DOACs that we thought they might have a part to play in the treatment of the antiphospholipid antibody syndrome. So approximately 6 years ago now, we published a trial called the RAPS trial. This is a trial of patients with venous thromboembolism, 28% of whom were triple positive for antiphospholipid antibodies, and 19% of whom had lupus. So in other words, the majority were the primary APS patients, but about 20% had lupus as well. We had 116 patients, and we divided them to 2 groups. Half the patients got rivaroxaban at the standard dose, of 20 milligrams per day. And the other half of the patients got warfarin with a target INR of 2.5. Remember, these are patients with venous thromboembolism, not arterial. And the primary aim was to show that the intensity of anticoagulation achieved with rivaroxaban is not inferior to that of warfarin. And the primary outcome was the percentage change in what's called the endogenous thrombin potential. And the results were to show no thrombosis or major bleeding in the 7 months of clinical follow-up with these patients. Assessing the percentage change in ETP alone, rivaroxaban appeared to be a little bit inferior, but in terms of peak thrombin generation, I'll show you some graphs shortly, it was lower with rivaroxaban, and overall, the thrombin generation indicated no difference in thrombotic risk. And in terms of quality of life, this was very much favored for those patients taking the rivaroxaban. Now, here's a kind of standard curve that we see with thrombin generation, and the ETP, or the endogenous thrombin potential, is the area under the curve, and that's what I want you to focus on. Because in this next slide, you can see that what rivaroxaban does, his warfarin and rivaroxaban, this is the look at this particular curve over here. You can see that rivaroxaban changes the shape of the curve, but in terms of the area under the curve, there's actually not much difference between these two, this graph over here with rivaroxaban and this graph with the warfarin. And thus we were able to say with some confidence that in terms of thrombin generation, there was nothing to choose between these two approaches. Unfortunately, for patients with APS, the trial by Vittorio Pengo and his colleagues, which came along just a couple of years later, was more concerning. They were, however, looking at patients with triple positive APS antibodies. These were patients with the antiphospholipid antibody syndrome. 120 patients. Again, these patients divided into those given rivaroxaban and those given warfarin, with a longer-term follow-up of over 560 days. And you can see that the concern is that 7 out of 59 patients had a thromboembolic event, compared to the warfarin-treated patients where there were no thromboembolic events. But remember, these are patients at very high risk because they were triple positive. There was a further study by Ross, which was also concerning in that there were a number of strokes seen in the rivaroxaban-treated patients, which were not seen in the warfarin-treated patients. There were some other minor differences, but these did not reach statistical significance. However, it's very important to recognize that warfarin given to patients is not without its problems longer term. And you do see recurrent thrombosis even in patients with APS given warfarin. They can continue to thrombose. And in fact, Pengo himself had the highest figure at close to 5%. So you mustn't think that when you put a patient onto warfarin, that's the end of the story. About 5% of these patients per annum will continue to thrombose, to have other forms of thrombosis. And that is a concern. There's also been a slightly odd trial that's been published relatively recently called the ASTRO-APS trial. This was using apixaban as a comparator compared to warfarin. And 35% of these patients had previous arterial events, and about 30% were triple positive for APL. Now, again, they reported a concern on the apixaban, 6 of 23 patients having ischemic strokes, compared to 0 out of 25 patients on the warfarin. But this was a very odd trial in that the doses of the medication changed twice during the course of the trial, and the study, in fact, ended prematurely. Although its conclusions, with marked limitations, actually suggest that apixaban was not a equitable substitute for warfarin to prevent thrombosis amongst APS patients. And these concerns from the Pengo trial, the Ross study, and the ASTRO-APS trial led to a concern that I'll come to in a moment with regard to the MHRA. Better news, however, from Quen and colleagues, who did a retrospective review of the effectiveness and safety of DOACs in all non-triple positive patients that they were following from 2010 to 2020. They had 50 patients, many years of follow-up, and they found no recurrent venous thrombosis with one possible arterial thrombosis. So their conclusions were rather different for these venous thrombosis patients. The DOACs were actually effective and safe as anticoagulation in non-triple positive thrombotic APS patients. So the current advice, the MHRA, the Medicines and Health Care Products Regulatory Agency, they advise that DOACs are not recommended for patients with a history of thrombosis diagnosed with APS, in particular for the triple positive patients. My own view is that this misses the nuance that actually for patients with venous thromboembolism, there really doesn't seem to be any evidence that DOACs are going to cause more of a problems. They do say in this guidance that DOACs may be considered for patients who have difficulty in achieving a target INR despite compliance with VKA, or those who have contraindications to the use of these products. So patients with APS, this is a recommendation by Tectono and colleagues from EULAR, and the first unprovoked venous thromboembolism they think first treatment should be VKA, and they recommended that. Viroxone should not be used in APS patients with triple APS positivity, and I think that's probably a reasonable position at the moment. But according to the advice of the International Study Group on thrombosis and hemostasis, there is an ongoing need for a prospective evaluation of DOACs versus VKA, that's essentially warfarin, in patients with provoked venous thromboembolism, particularly in those without triple positive disease. In order to answer this sort of question, Professor Cohen and I and our colleagues in London are doing exactly that. We're doing a phase 2b trial, the RISAP study. These are patients with single or double positivity only for the antiphospholipid antibodies. They have a history of the antiphospholipid antibody-linked ischemic stroke or other forms of ischemic brain injury. And we've divided these patients into those on warfarin who have a target INR of 3 to 4, and we're giving these patients a higher dose than normal of rivaroxaban. Rivaroxaban is usually given at 20 milligrams total. We're giving it at 30 milligrams total. We need to get 40 patients. As of yesterday, we were up to about 38 patients, so we hope to complete the collecting all these patients together within the next couple of weeks. And the primary assessment here, because of the unfortunate problem that we have with clinical events are rather uncommon in these patients, is the rate of change in brain white matter hypertensity volumes between baseline and 24 months of follow-up. So this is a surrogate marker of ischemic change. So in summary, it appears that DOACs can be given to APS patients with venous thromboembolic disease, especially if they are not triple positive. They should not, in fact, be given at standard doses, rivaroxaban 20 milligrams per day, to the triple positive APS patients. What remains uncertain is whether standard dose DOACs can be used safely in the patients with a history of arterial events, in those with single or double positivity. We don't know the answer to that yet. And whether or not 30 milligrams per day will prove to be safe and successful, we just don't know. Our results are, I can't tell you very much at the moment. We've been doing this study for about a year, seem relatively encouraging. So are DOACs dead? No, I think they're still alive, but not in perfect health, and not terminal either. So, ladies and gentlemen, I've tried to highlight a very interesting area of ongoing research in patients who have APS and lupus. Lupus remains a particularly difficult disease to manage, especially in the presence of an additional condition. And APS is found to complicate approximately 10% of patients with APS. And the best way to treat the APS, either primary or secondary, is still under constant review. Thank you very much for listening.
Thank you, Professor Eisenberg, for such a detailed talk on lupus and APLS, especially about anticoagulation. Now we move to our third speaker of the session 1. We will really miss him in this year's Congress, and hopefully he'll join us next year in person. The next talk is by Professor David De Cruz. He is the consultant rheumatologist at Lewis Lupus Unit, Guy's Hospital, Great Maze Pond, London, and he will be talking on neuropsychiatric lupus.
Inviting me to give you this lecture on neuropsychiatric lupus. This is your 25th Silver Jubilee meeting of the PSR, and I'm really very sorry I can't make it in person for a whole variety of reasons, but thank you again for the invitation. These are my disclosures. So neuropsychiatric lupus remains the black box of lupus diagnosis and management. It is complex, it is poorly understood, and it is difficult to diagnose with certainty. So the classic presentations that most medical students will know about are hallucinations and psychosis and seizures. And treatment options are intravenous steroids, cyclophosphamide, rituximab, or mycophenolate. So let me start with an example. A 35-year-old female presented at the age of 17 with joint pains. Age 19, she developed serositis. Imaging was negative for pulmonary emboli, and she obviously had lupus, very strongly positive ANA, anti-DNA antibodies, low complement, and she was diagnosed with SLE and commenced on low-dose steroids and hydroxychloroquine. From the outset, she was positive, triple positive for antiphospholipid antibodies, lupus anticoagulant, anticardiolipin antibodies, and beta-2 glycoprotein-1 antibodies. So some years later, she presented with a flare, with rash and arthritis. And on this occasion, she had pyramidal signs. She had increased tone, brisk reflexes, flexor plantars, a marked expressive dysphasia, and cerebellar ataxia. The concern was, here's a woman with lupus, very strongly positive lupus serology, and quite extensive neurological presentation. The question was, did she have cerebral vasculitis? Imaging showed extensive cortical infarctions and small vessel disease, as you can see here on the scans indicated by the arrows. There was no stenosis or beading or microaneurysms, and given that she was triple antiphospholipid antibody positive, the diagnosis here was not cerebral vasculitis, it was lupus and cerebral antiphospholipid syndrome. And she was started on warfarin and actually responded reasonably well to warfarin. So what is the prevalence of neuropsychiatric syndromes? There's a huge range of prevalences in the literature, ranging from quite 5, 10, 15% right all the way up to 95%. In other words, the majority of patients. The problem here is that only a third of these symptoms are directly attributable to lupus. This may be due to differences in definitions and attribution of the symptom to lupus. Selection and referral bias clearly play a role. Tertiary referral centers will see, by definition, more severe patients, and these patients are more likely to be diagnosed with neuropsychiatric lupus. Neuropsychiatric lupus is more common in women of African, Asian, or Aboriginal ancestry. So you'll be aware that in 1999, the ACR drew up 19 distinct syndromes that can be seen in lupus, 12 central syndromes listed here, and 7 peripheral syndromes listed here. The difficulty here is that none of these are specific for SLE, and certainly not all need immunosuppression, particularly headache and mood disorder. So what about the symptoms of neuropsychiatric lupus? Over 25 years of seeing these patients, I've come to observe that nightmares are associated with neuropsychiatric lupus. So how does this come about? Patients do not like talking about hallucinations. They fear that you will lock them up in a psychiatric ward and fill them full of antipsychotic drugs. So usually when I suspect somebody may have neuropsychiatric lupus, they've got active lupus, strongly positive serology, I usually start by asking them, how are you sleeping? Universally, they'll say, I sleep badly. My next question is, do you have nightmares? And increasingly, patients are saying, yes, I have nightmares. These are frequently very frightening nightmares, people trying to kill them, relatives dying, and they are very terrifying. I then ask them, do you have nightmares when you're awake? In other words, are you seeing things or hearing things or feeling things touching you? And then the whole story comes out that they've got psychotic symptoms. You can then reassure them that actually this is due to your lupus and you're not going mad. So I've been working with Melanie Sloan, who's a clinical psychologist from Cambridge, and this is very, very, very preliminary qualitative questionnaire data. So Melanie sent 500 lupus patients this questionnaire and sent the same questionnaire to 418 healthy friends of those lupus patients. And this is some very, as I say, unpublished preliminary data. So the questionnaire has reported that 16% of the lupus patients reported hallucinations compared to 4% of the healthy friends. 21% reported mania compared to 8% of the healthy friends. And surprisingly, 57% reported disrupted dreaming sleep, including nightmares, compared to only 31% of the healthy friends. And very worryingly, suicidal thoughts were reported by just about a quarter of the lupus patients and only 12% of the healthy friends. So this is very revealing data, and it's subject to intense research by my neurology and neuropsychiatry colleagues and clinical psychology colleagues. So what's the pathogenesis of neuropsychiatric lupus? So primary neuropsychiatric lupus can be due to a vasculopathy, usually in the context of antiphospholipid antibodies, less so with inflammatory mediators. And the usual presentation is with focal disease. On the other hand, the diffuse disease that you see with psychosis and nightmares is usually due to autoantibody and cytokine-mediated disease. Anti-ribosomal P and anti-NR2 glutamate receptor antibodies, less commonly antiphospholipid antibodies. And these patients are driven mainly by cytokines. This is a sort of cytokine storm in the brain, if you will. So focal disease and diffuse disease. The problem here is that these two syndromes can be due to secondary neuropsychiatric lupus or indeed non-lupus neuropsychiatric disease. These syndromes can be due to complications of lupus, as I will demonstrate, uremia, hypertension, and posterior reversal encephalopathy syndrome, and complications of treatment, including infections. We have one patient with active lupus who had cerebral TB, and that was very challenging. So how do you diagnose neuropsychiatric lupus? Well, as with any aspect of lupus, thorough, careful history, full systems examination, thorough neurological examination, including fundoscopy, looking for these white matter lesions, the cytoid bodies that are a hallmark of neuropsychiatric lupus. Your standard screening investigations, biochemistry, hematology, serology, infection screen, cerebral imaging, lumbar puncture, nearly always, and EEG, looking for encephalopathy. These patients are always managed in the context of neurology and psychiatry colleagues. So what's the role of cerebral imaging? Well, really is to distinguish cerebral disease due to lupus from other causes. And my experience is that other causes are more common. So often, even in patients with active neuropsychiatric disease, the cerebral imaging is normal or they're very non-specific changes. You can see cerebral vascular ischemia or small vessel disease, as I illustrated earlier, and you can see demyelination, which I will come back to. So here's a classic example. This is a young woman in her 20s, originally from Nepal, very severe lupus nephritis, severe hypertension, developed seizures. And the imaging shows gross swelling here of the basal ganglia and posterior white matter lesions. A couple of weeks later, with treatment of her hypertension, the lesions have resolved. So this is posterior reversible encephalopathy syndrome, in her case, directly related to the hypertension and active lupus, and she had lupus nephritis. And this is due to a loss of cerebral autoregulation or vasogenic cerebral edema. And full recovery in 90%, usually within a week, is the norm. So that leads me on to antiphospholipid syndrome, characterized by thrombosis and pregnancy morbidity in the context of antiphospholipid antibodies as shown on the slide, so arterial and venous thrombosis. So the difficulty here is that antiphospholipid syndrome and lupus are separate syndromes. Antiphospholipid syndrome can cause cerebral antiphospholipid syndrome, and lupus can cause cerebral lupus. The problem here is that these two conditions can occur in the same patient, and this is a really very challenging scenario. This is a study by my colleague Giovanni Sana, who surveyed 185 lupus patients with the ACR classification criteria for neuropsychiatric lupus. I've asterisked the one here, the syndromes here that are associated with antiphospholipid antibodies. So headache, cerebral vascular disease, cognitive disorders, seizures, and transverse myelopathy are all antiphospholipid syndrome associated, at least in this study. And this has been confirmed by many similar studies. So this is the spectrum of cerebral antiphospholipid syndrome as opposed to cerebral lupus. So in cerebral APS, you have headaches, cognitive dysfunction, ischemic strokes, TIAs, ischemic encephalopathy, amaurosis fugax, venous sinus thrombosis, chorea, transverse myelopathy, and seizures. So as I said, thorough examination, including fundoscopy. Here's a lady with lupus with antiphospholipid syndrome who has developed a branch retinal artery occlusion related to her antiphospholipid syndrome. So what about cognitive dysfunction? This is a big problem in lupus. With cognitive dysfunction, there's a strong association with antiphospholipid antibodies. These patients have decreased attention spans, poor concentration, poor information processing speed. The question here is cognitive dysfunction due to damage or inflammation, or in some cases both? And that can be very challenging to identify. So turning around to seizures, there are many, many studies in the literature. This is a large study of over 500 patients with lupus, 60 of whom presented with seizures. Generally, seizures present either at diagnosis or in the first year after diagnosis. There's a very strong association between seizures and antiphospholipid antibodies and stroke, particularly, as you can imagine. So what about valvular disease? There is a strong association between the so-called Libman-Sachs endocarditis and antiphospholipid antibodies. And as you can imagine, there will be an increased risk of embolic phenomena with small vessel cerebral disease and splinters. And there's a strong association with antiphospholipid antibodies and libido reticularis. So turning now to demyelinating syndromes in SLE, so multiple sclerosis-like syndromes less than 1%, and myelopathy in around 1%. And again, this is very similar to many studies in literature. So how do you distinguish multiple sclerosis from antiphospholipid syndrome? This was a study, blinded study by my colleague Maria Quadrado, who took 25 scans from MS patients. These are straight on MS patients, not lupus, not antiphospholipid syndrome. And she took scans from 27 APS patients and just put the scans up in front of the radiologist and said, can you distinguish MS, multiple sclerosis, from antiphospholipid syndrome? The answer was no. The lesion score tended to be higher in MS. You can see here the so-called Dawson's fingers here. This is a patient with APS. So you cannot distinguish APS from MS just on the individual scans, and the clinical features can be similar. And here's another common scenario. You see a patient in clinic with active lupus with some neurological symptoms. You do an MRI scan, back comes the report from the radiologist, consistent with vasculitis. In fact, in reality, these lesions are much more likely to be antiphospholipid syndrome related, so-called small vessel disease. That leads on to the question. So you've got a young woman, and you see these imaging findings of small vessel disease, and they're positive for phospholipid antibodies. Should you anticoagulate them? Generally, the answer is no. We've avoided anticoagulating these patients. Now we've changed our approach. So if they are clinically silent, we offer them aspirin, but mainly it's intensive cardiovascular risk factor management. In the context of lupus, they will be on hydroxychloroquine, but you might consider adding statins. However, if you see these changes with severe cognitive dysfunction, and especially if they have neurological symptoms and signs, we would anticoagulate these patients, usually with warfarin, perhaps after a trial of heparin. So transverse myelopathy, a classic sign of demyelination in lupus. Here's a woman, African ancestry patient, presenting with a rapidly progressive myelopathy and low limb paresis. You can see the extensive myelopathic changes here in the cervical cord going right up to the pons. She had strongly positive lupus serology. She responded to intravenous cyclophosphamide and made an almost complete recovery. You can see here just a few months later, the imaging has improved. The etiology of transverse myelitis is uncertain. One could consider that this is an inflammatory lesion, and indeed CSF findings often show elevated levels of cytokines, for example, IL-6, and these tend to respond to immunosuppression, cyclophosphamide or rituximab or mycophenolate. It can be, however, thrombotic in association with antiphospholipid syndrome, and about 2/3 of our patients with transverse myelitis presented, that was the first presenting feature of their lupus, and they were positive for antiphospholipid antibodies. And they can respond to anticoagulation, but this is very controversial. However, here's a patient who had extensive livedo reticularis, triple antiphospholipid antibody positive. She had lupus. She'd not had any thrombotic events, so she wasn't anticoagulated. But sadly, she ended up having a spinal artery thrombosis and transecting the spinal cord. And you can see that this was quite a serious event from which she had a fatal outcome. So what about, I've mentioned cerebral vasculitis only to dismiss it and say it's rare, but what about true vasculitis? Here was one of my patients, not lupus. This is primary angiitis of the central nervous system. You can see very dramatic changes on the MRI scan here, these extensive white matter changes. And she underwent a brain biopsy, and you can see the classic features of cerebral vasculitis. Here's a cerebral vessel, almost occluded by inflammatory cells and surrounded by inflammatory cells. So this is true cerebral vasculitis. So what about lupus and cerebral vasculitis? This is actually very, very rare. Around 10% of post-mortem studies in patients who are thought to have died of cerebral lupus, only 10% showed true cerebral vasculitis. However, if you do have true cerebral vasculitis, mortality is very high. 2/3 of patients will die, even in expert hands. And here's one of my patients who sadly died from true cerebral vasculitis. You can see here she's had a subarachnoid hemorrhage due to vasculitis of the circle of Willis. So what are the MRA pointers to vasculitis in lupus? You can see enhancement in vascular wall thickening. You can see vascular stenoses, beading, ischemic lesions, and occasionally intracerebral or subdural hemorrhages. There are a number of series in the literature, case reports of seizures and coma in association with cerebral vasculitis. In this study, one patient had a fatal outcome. You can see the extensive changes on the imaging of true cerebral vasculitis. Histology shows necrosis and nuclear debris here in keeping with necrotizing vasculitis. And you can see here, this is a vessel that's been disrupted by focal endothelial disruption by inflammatory infiltrates. Here's another example, 25-year-old lady from India originally, age 20, develops typical lupus with arthralgia, photosensitivity. She then develops cerebral lupus with psychosis and extensive neurological deficits, lupus nephritis and myocarditis, strongly positive lupus serology, and she had severe lupus. Her imaging was highly suggestive of cerebral vasculitis. You can see this extensive white matter changes here on the MRI, and you can see on the MRI angiography, you can see beading and stenoses here. So we were fairly convinced that she had true cerebral vasculitis, and indeed she responded to intravenous cyclophosphamide. Here's another of our patients who had neurological deficits, antiphospholipid antibody negative, who did respond also to cyclophosphamide, and you can see there is some clearing of the imaging findings. Neurologists tell us about this little sieve vitamin to identify causes of or associations of neurological syndromes, vascular strokes related to antiphospholipid syndrome, infection, traumatic, not relevant to this audience, autoimmune, in other words, directly attributable to SLE, metabolic, iatrogenic, and neoplastic. So here was a patient, middle-aged lady from West Africa who had lupus, who truly did have cerebral vasculitis. She presented with lesions much smaller than this. She underwent a brain biopsy, which confirmed cerebral vasculitis, and she responded to cyclophosphamide. Several years later, she represented with neurological deficits, and she was aphasic. And you can see this extensive white matter lesion here in the right frontal lobe with a progressive hemiparesis. She was negative for antiphospholipid antibodies, and indeed her lupus serology was negative. So the question was, did she have cerebral vasculitis? We did a PET scan, which showed intense FDG uptake in the frontal lobe. And because of the strong suspicion of cerebral vasculitis, she underwent a brain biopsy again. So the brain biopsy showed extensive infiltration of CD20 positive B cells, which were proliferating. And indeed, she turned out to have a high-grade cerebral B cell lymphoma, not vasculitis at all. So you can get caught out now and again. So in terms of treating CNS disease, confirm the diagnosis. As I've just demonstrated, this is not easy. Trying to attribute the syndrome to the lupus can be very, very difficult and challenging. Patients with seizures and psychosis, you need your neurological colleagues to help you with the anticonvulsants, and your psychological colleagues and the neuropsychiatrists in particular to help with psychotropic medication. Always look out for and treat comorbid conditions, electrolyte imbalances, severe hypertension, and infection. So this very simplistic slide divides patients with focal presentations, TIAs and strokes, positive antiphospholipid antibodies. These patients need anticoagulation with warfarin, and that is warfarin as opposed to the direct oral anticoagulation. Warfarin is the gold standard for cerebral antiphospholipid syndrome, not the direct oral anticoagulants. Diffuse disease, a bit more challenging, organic brain syndromes, positive lupus serology, we would consider immunosuppression. But there are patients, as I've demonstrated, who have both antiphospholipid syndrome and organic brain syndrome, and these patients usually end up being treated with warfarin and immunosuppression. So in summary, neuropsychiatric lupus cerebral disease is very, very complicated. There's a wide differential diagnosis. True cerebral vasculitis, as I hope I've demonstrated, is very, very rare. Lupus and antiphospholipid syndrome is a very challenging combination. Attribution of the clinical event to lupus and or antiphospholipid syndrome is possible, but can be very challenging. Look out for other comorbidities and treat them. And very clearly, multidisciplinary care improves outcomes. And if in doubt, refer early to a specialist center. So these are all my colleagues who've helped me with these incredibly challenging patients. Thank you again for your attention, and many thanks again for the invitation. And I hope you do celebrate your 25th PSR anniversary. Thank you for your attention.
Thank you so much, Professor De Cruz. You always give an inspiring talk and inspire us in any talk you give. Now, let's move on to the fourth talk of this first session. That would be given by Professor Ali S.M. Jawad. He is the consultant rheumatologist at Royal Hospital London and Centre of Experimental Medicine and Rheumatology at VHRIQM University of London, and he would be talking on diagnosing and treating neurosarcoid.
Ali Jawad. I'm a professor of rheumatology at the Royal London Hospital and Queen Mary University of London. I'm going to talk about neurosarcoidosis today. I've just to say that I'm grateful to my colleague, Dr. Desmond Kidd, who's a neurologist, for providing me with some of the images, but I have nothing else to declare. Now, the outline of this talk is to introduce sarcoidosis and then to talk about the clinical manifestations of neurological involvement of sarcoid. I will talk about the cranial and peripheral nerve involvement, the brain and the spinal cord, hypothalamic, pituitary, and pituitary involvement, and myopathy. In the end, I'll talk about diagnosis and treatment. Now, sarcoidosis is a multi-system granulomatous disease of unknown etiology. It affects individuals really all over the world, and it is characterized by a non-caseating granuloma in the involved organs. The granuloma always looks clean, obviously without necrosis, and it typically affects young adults and initially presents with one or more of the following abnormalities, usually bilateral hilar lymphadenopathy or pulmonary reticular shadowing, sometimes skin, joint, and eye involvement. The commonest eye lesion is uveitis. And the sarcoid granuloma is really the center of the granuloma is full of macrophages, epithelioid cells, multinucleated giant cells, and T lymphocytes. They tend to be CD4 positive T helper 1 cells. Around the macrophages and the multinucleated giant cells are CD8 and CD4 positive T lymphocytes, B lymphocytes, monocytes, mast cells, and fibroblasts. And on the outer ring, there is hyaline collagen. And you could see some of the multi-giant cells here, the granuloma, with a lot of lymphocytes in a biopsy of the skin. Now, the main cytokine in sarcoid granuloma is interferon gamma. Interferon gamma is essential in the formation of sarcoid granuloma. And it is, in fact, a highly polarized Th1 cytokine response. And there is also TNF alpha, but its role is less than the interferon gamma. And other cytokines like IL-2, IL-6, IL-12, 18, 27, they in fact enforce the secretion of interferon gamma, and IL-8 is a very potent chemotactic factor to recruit macrophages, monocytes to the granuloma to form the giant cells. And sarcoidosis, its prevalence is between 10 to 20 per 100,000. It's 3 to 4 times more common in African in people of African origin, and they tend to have more acute disease with more severe disease, while whites tend to present really with chronic disease or asymptomatic disease. It does aggregate in families, and there is a higher prevalence of thyroid disease, connective tissue, or immune-mediated diseases, and MS. Its prevalence is highest in Nordic countries like Denmark, Finland, Iceland, Norway, and Sweden, and it's lowest in Southeast Asia countries like Korea, Japan, and Taiwan. Generally, African American have 3 times the incidence of European Americans in the States, and it's lowest in Hispanics. You can see the annual incidence of 11 per 100,000 in America and in Sweden. In the UK, slightly higher. Generally, the mean age of onset is between 45 to 55, although some types occur in younger people. It tends to occur later in women, and it is more common in women. Interestingly, a case series suggested that exposure to the World Trade Center dust during collapse, rescue, and recovery was associated with an increased incidence of sarcoid-like granulomatous pulmonary disease. Also, increasingly recently, patients treated for cancer with chemotherapy, they may develop lymphadenopathy in the area of cancer, and when you biopsy these lymph nodes, they also show a sarcoid-like reaction. And we also know that etanercept and adalimumab, they could induce a sarcoid-like reaction. Now, stage 1 is just bilateral chiral lymphadenopathy. This is the staging. If there is reticular shadowing and infiltrates with the lymphadenopathy, that's stage 2. Stage 3, when there is infiltrates on their own, and stage 4, when there is fibrosis. Now, why does fibrosis happen? Because in some patients, the Th1 response shift to a Th2 response. Th2 secretes interleukin-4, which causes the production of extracellular matrix proteins, and these attract fibrocytes and hence the fibrosis. And you could see it here in a CT scan. And the outcome is generally a stage 1 and stage 2 recover very well. Obviously, stage 3 and stage 4, the recovery is less clear. And generally, 30% resolve within 2 years, 30% relapse, and 30% have a progressive disease. Mortality is relatively low at 7%. So we're going to talk about the neurological involvement, and you can see it's around 5% of all patients with sarcoid, and more common in females than in males. And half of the patients with the neurosarcoidosis present with the neurological symptoms and signs at the onset of sarcoid. 1/3 of those with neurosarcoidosis have more than one neurological manifestation of the disease. And as I said earlier, it could be could be a peripheral neuropathy, either cranial or peripheral neuropathy. The brain and the spinal cord could get involved, including the corda equina, the hypothalamic and or pituitary involvement, and muscle involvement. The cranial neuropathy, by far the commonest, is a facial nerve palsy, and it accounts for 70% of all isolated neuropathies. It's generally unilateral, and imaging is only positive in half of the cases. You could see, for example, there is enhancement in the area where the left facial nerve is, and sometimes there is more widespread disease. Typically, when facial nerve palsy occurs with uveitis, fever, and a parotid enlargement, it is referred to as uveo-parotid fever or Herford syndrome. The cervical lymphadenopathy would show granulomas, and also the parotid and the submandibular gland. The second nerve to be commonly affected would be the optic nerve, but generally it is subacute in onset. Very rarely there is bilateral optic nerve involvement, but it can be sequential. You could develop optic neuritis in one eye followed by the other. And it can also, very similar to Herford syndrome, be associated with uveitis. And other other cranial nerves could get involved: oculomotor, the 3rd, the 4th, and the 6th, as well as the trigeminal and the 8th cranial nerve could get involved. You could see in this CT scan there is involvement of the 3rd ocular nerve. Lower cranial nerves and the eighth nerve could get involved due to either basal meningitis, lepto, or pachymeningitis. We'll talk about that soon. Isolated hearing loss is uncommon, and weakness and hemiatrophy of the tongue due to involvement of the hypoglossal nerve can occur, but extremely rarely. Peripheral nerves can get involved, but again, it's very rare. It could be just sensory motor or pure sensory. And on nerve conduction studies, it's generally axonal in type. Mononeuritis multiplex may occur, and very rarely an acute inflammatory demyelinating polyradicular neuropathy can occur, usually at the onset of disease. Again, it's extremely rare. Some patients have small fiber and autonomic neuropathy. Again, this is extremely rare. Small fiber neuropathy will yield normal nerve conductions, but you have to ask the neurophysiologist to do a thermal threshold to discover that type of neuropathy. Pituitary and the hypothalamic could get involved. It is not only the hypothalamus, but the pituitary stalk and the pituitary gland. Those patients could present with diabetes insipidus and generally gradual pan-hypopituitarism. They could have more widespread inflammation, as in this case, and pituitary function generally does not recover once it's lost. Headache is one of the commonest presenting features. Here you could see in these pictures the involvement of the pituitary, and this is the involvement of hypothalamic disease, which you clearly see in that in these cuts. Now, the brain can get involved either through pachymeningitis. The pachymeninges is the dura. It's the outer part of the meninges, is the which in fact lines the skull from inside. The leptomeninges is the arachnoid and the pia mater, and so it is the soft, in a way, or the thin part of the meninges. And obviously we could get granulomatous vasculitis in sarcoid. And it could be the pachymeningitis. It could be the convexity of the cranium, or it could be the base. And half of the patients present with either a mass, focal and neurological signs, and often associated with seizures. Sometimes the appearance on the MRI scan is very similar to demyelinating disease, to MS. You get the in-plaque type. Headache, again, is very common. If the cavernous sinus is affected, and therefore the orbital apex is involved, then the patient could present with diplopia, double vision, optic neuropathy, and pain at the back of the eye. Imaging is always abnormal in pachymeningitis, and the CSF is always active with high proteins, lymphocytes, and lower CSF plasma sugar level. This is another patient. You could see the orbital apex is affected, and the right cavernous sinus. I think this picture is much better. And this patient presented with headache, focal neurological signs, and seizures. Sometimes the disease is very widespread. You could see here, for example, the convex part of the dura is affected, and you could see some in the base. This is all sarcoidosis. Now, pachymeningitis is a progressive and widespread, but headache could be the only sign. Again, you could see the pachymeninges involvement in this case. Now, leptomeningitis is more aggressive. So because you could say it's nearer to the brain and the spinal cord. And 3/4 of these patients have invasive and destructive meningoencephalitis. And 2/3 of these patients could present with sign of diencephalic dysfunction and hydrocephalus, and a third have signs of involvement of the brain stem, very similar to Behçet's, associated with hydrocephalus. The basal meninges are more commonly involved than the convexities. We saw the few scans earlier of pachymeningitis, where it was mainly the convexities that are affected. Again, the disease is subacute, but it could be increasingly rapid with accrual of severe symptoms. Now, generally, these patients are more disabled than those with a pachymeningitis, and the two processes do not overlap. So patients who have leptomeningitis do not seem to have features of pachymeningitis, and the other way around is also correct. Again, CSF and imaging are always abnormal. You could see the basal involvement in this case. This is again, this is the outer convexity. The right parietal lobe is affected from the meninges. You could see that here as well. So seizures are really quite common. This is you could see these are nodules in the ependymal area. Could you see that? These are all granulomas. And this is, again, you could see when the disease, in a way, affect the orbital apex, it will affect the optic nerve. You could see here, that's the apex of the right orbit, and these patients would have symptoms and signs of right optic neuropathy. But you could see here the disease is very widespread, but again, it's mainly basal rather than in the convex part of the brain. Now, vasculitis, it's generally, obviously, it's a granulomatous vasculitis, usually within the leptomeninges, and it spreads to involve the brain or the spinal cord tissues. And it's usually the small and medium-sized vessels. In the wall, you'll see macrophages, epithelial cell invasion, and the inflammatory response could be so severe it disrupts the internal elastic lamina, causing fibrosis, and sometimes it causes even bleeding, and infarction could occur because there is occlusion or stenosis of the blood of the lumen. I could show you here this patient with right cerebellar infarct. Sorry, let me go back. And here there is the right cerebellar infarct, and there is the midbrain infarct on the left side. And there you can see here there is quite a bit of perivascular enhancement, but the MRI could be normal, and you could see here a bleeding has occurred from an involved vessels, quite extensive bleeding. And again, this is clearly seen, and this patient did not survive, and you could see the granuloma clearly and the disruption of the elastica, hence the bleeding. See these massive giant cells and the intense granuloma. But it's always, my wife, who's a histopathologist, always tells me that the sarcoid granuloma looks very clean on histology. Now, the spinal cord and the chorda equina could involve. Obviously, the spinal cord is really mainly it's involved as a result of leptomeningeal involvement, and less so from pachymeningeal involvement. And in 10%, it's intrinsic within the cord. You could see you could see the these enhancement, the granulomas along there's another one within the cord itself. It's generally subacute rather than and very slowly progressive, and it's in the cauda equina patients with cauda equina lesions. They would have a painless sensory and sphincteric loss of sensation. You could get thoracic radicular neuropathy, as in this case, but generally those present very early in the disease. These are some of the MRI imaging. You can see the granuloma here, another one there, and diffuse involvement of the cord in the upper thoracic area. Again, you could see all these lesions. They could be very widespread. This is mainly due to this is to leptomeningeal involvement. Interestingly, this patient also has Schmarl nodes. The cauda equina, again, they present very similar to any cauda equina lesion, but they tend to be less acute. There is loss of sensation, perianal area, sphincteric loss, and quite often bilateral absence of the ankle jerks. But sometimes this syndrome could resemble motor neuron disease, especially amyotrophic lateral sclerosis. As I said, it's the whole cranium and the spinal canal could get involved in both leptomeningitis and pachymeningitis, but more so in leptomeningitis. But sometimes you get isolated disease of the cord and the cord, isolated in fact disease of the spinal cord and the cauda equina does occur in patients without cranial involvement. And as we said, it tends to be subacute. And there is, in fact, enhancement, you can see in this patient, of the inflamed nerve in this patient. Now, sarcoid myopathy is not very significant. Generally, it's asymptomatic. It's only 0.5% of all patients with muscle involvement are symptomatic. Chronic myositis is the commonest. It's similar to any type of proximal of polymyositis with proximal muscle weakness, elevation of the CK, and myopathic nerve EMG. Acute myositis, more common in women. Again, very similar picture. Nodular myositis is the least frequent, and generally you will see tender nodules, especially in the calf muscle. Again, this is a muscle biopsy. You could see the beautiful granulomas within the muscle biopsy, very clean. Now, diagnosing sarcoidosis in general may be difficult, and it's best if we're talking about sarcoidosis in general, biopsy is the gold standard, unless the patient presents with Lofgren syndrome, bilateral hyaline large joint arthritis, and erythema nodosum or locus pernio. You need, obviously, the chest X-ray, the CT and HRCT are important. A gallium scan, but more importantly, a PET scan, generally is very useful in picking up the diagnosis, because the gallium and the FDG is picked up by the granulomas. The Klein test is no longer used. This is a patient who was noted to have who had active myocarditis, and they did an FDG PET scan. This is from the Hammersmith, and you can see the increased uptake within the muscle in the left ventricle, and that was in keeping with sarcoid. He had a biopsy, and that proved to be sarcoidosis. You could see the nerves, the wires of the pacemaker, and also you could see in the background increased uptake within the lungs. So this this patient did have lung involvement. You can see there is very active lung involvement, and the mediastinal lymph glands are positive. This is really, in a way, typical of sarcoid. It's very important you do an IGRA test to make sure exclude tuberculosis, and generally a positive test, a strong positive test excludes sarcoidosis. The ACE is not very useful at all. In fact, it has no diagnostic value because of its low specificity. And you can see it's increased in patients with diabetes, TB, lung cancer, even hyperparathyroidism. So ACE is no good. But when it comes to neurosarcoidosis, the MRI scanning with contrast is abnormal in all patients with central nervous system involvement, but not necessarily abnormal in patients with isolated cranial neuropathy. As I said, the CSF in untreated sarcoid is always active, high protein lymphocytosis, and the CSF plasma glucose ratio is low. Now, the treatment, sarcoidosis, unlike other similar diseases, is very sensitive to corticosteroids. 60 milligrams of prednisolone generally is enough to make the patient feel better within few days, and the symptoms improve and the disease progression slows down. We have found that that methotrexate is best added in patients' neurosarcoidosis, both as an immunosuppressive agent and also as corticosteroid sparing. We have found, and Dr. Kidd also tells me that mycophenolate and azathioprine, although used, but generally they are not as effective. Infliximab is very effective if there is ocular disease and severe neurosarcoidosis, especially those with severe uveitis and brain involvement. But one has to be careful because the anti-TNF agents could, in fact, induce a sarcoid-like reaction. But it's best reserved for patients with ocular and severe neurosarcoidosis. And in summary, neurosarcoidosis is uncommon, occurring in only 5% of those with systemic disease. It's more common in women, and 70% have mild disease, usually in the form of cranial, peripheral, and peripheral neuropathy and radiculopathy. 30% have severe central nervous system involvement, requiring corticosteroids and methotrexate. Those with severe disease at onset and those who are treatment unresponsive may need TNF-alpha antagonist infliximab. And thank you very much.
Thank you, Professor Jawad, for giving an excellent talk on a difficult topic. Now we move on to the last talk of this session, that would be given by Professor Masayoshi Harigai. He's the professor and head division of rheumatology at the Department of Internal Medicine, Tokyo Women's Medical University School of Medicine, and he would be talking on vasculitis year in review.
Hello, ladies and gentlemen. I'm Masayoshi Harigai from Tokyo Women's Medical University, Tokyo, Japan. Thank you very much for inviting me to the 25th Pakistan Society of Rheumatology Conference. I would now like to take 30 minutes of your time to present some important research papers in vasculitis over the past year. Please forgive me for not being able to present all the important references due to time constraints. My conflicts of interest are shown at the bottom of the slide. In my talk, I'd like to include two topics. The first one is small vessel vasculitis, and followed by large vessel vasculitis. I searched publications in 2021 and 22 using PubMed. From a number of literatures I came up with, I would like to focus on clinical aspects of vasculitis today. Now let's move on to the first part. Diagnosis and classification criteria in vasculitis DC-VAS project has been implemented in the past few years. Patients with vasculitis or comparative diseases were recruited into this international cohort as shown in the slide. In total, about 7,000 patients, including 5,000 cases and 2,000 comparators were recruited. In the case of classification criteria for eosinophilic granulomatosis with polyangiitis, EGPA, 91 items from the DC-VAS case report form were retained for lasso regression analysis, and 11 items were selected. Based on clinical significance and specificity to EGPA, 7 items were finally included in the new classification criteria. This slide shows the ACR-EULAR classification criteria for EGPA. The point is that these classification criteria should not be used for diagnostic purpose. A diagnosis of small or medium vessel vasculitis should be made first, and then the criteria for EGPA as well as MPA and GPA can be applied to. Each item of this criteria has its score, and the total score equal or more than 6 is needed to be classified as EGPA. It should be noted that obstructive airway disease, but not bronchial asthma, is used as a terminology of the first item, and that hematuria has a negative score. In the validation set, sensitivity was 84.9%, specificity was 99.1%, and AUC, area under the curve, was 0.99. The diagnostic ability was much better than the previous ACR criteria. The classification criteria for granulomatosis with polyangiitis GPA was developed in the same manner. This criteria seems to be very straightforward and includes several relevant clinical, laboratory, imaging, and biopsy features of GPA. In the validation set, the sensitivity was 92.5%, specificity was 93.8%, and AUC was 0.99. Compared to the previous ACR criteria, the new one showed very good classification ability. This slide shows new ACR-EULAR classification criteria for microscopic polyangiitis, MPA. As you know, there was no ACR or EULAR criteria for MPA, and almost all pivotal clinical trials for MPA used 2012 Chapel Hill Conference definition for eligible criteria. In the new criteria for MPA, fibrosis or interstitial lung diseases on chest imaging has been incorporated as an item with a positive score of 3. Nasal involvement, positive PR3 anchor, and increased eosinophils have negative scores in this criteria. The sensitivity of this criteria was 19.8%, specificity was 94.2%, AUC was 0.97. Next, I'd like to briefly touch on new biomarkers for MPA and GPA. In a clinical setting, rheumatologists and nephrologists use CRP or ANCA as biomarkers to follow up their patients with MPA or GPA. Dr. Ishizaki at Ehime University in Japan reported tissue inhibitor metalloproteinase TIMP1 as a very useful biomarker for MPA and GPA. As shown in the upper panel of the slide, TIMP1, CRP, MPO ANCA, and PR3 ANCA all decreased significantly 6 months after starting remission induction treatment. The lower panel shows that among these biomarkers, only TIMP1 could discriminate patients in remission and those with mild disease activity at that time point. Dr. Ishizaki next measured serum TIMP1 level in 45 patients who achieved remission 6 months after starting treatment for MPA and GPA. These patients were followed for further 18 months. The left panel shows that patients who experienced relapse during the 18-month follow-up had higher levels of TIMP1 than those who sustained remission. As shown in the right panel, the high TIMP1 group that was equal or higher than 150 nanogram per ml showed a higher relapse rate than the low TIMP1 group. Now, let's move on to the treatment for MPA and GPA. There are several treatment targets in the common pathogenic pathways in MPA and GPA. Targeted therapies aiming at these molecules are summarized in the next slide. Several biologics or small molecules have been developed for the treatment of MPA and GPA, and rituximab and avacopan are currently available in clinics. One of the great advances in the past 2 years is that non-inferiority of low-dose glucocorticoid or low-dose GC to high-dose GC was demonstrated when used concomitantly with rituximab or cyclophosphamide. Furuta and his colleagues compared the low-dose GC and high-dose GC in combination with rituximab in patients with MPA or GPA in low-VAS study. The low-dose GC group started prednisolone from 0.5 milligrams per kg per day and tapered and stopped it at week 21. The high-dose GC group started prednisolone from 1.0 milligrams per kg per day and tapered to 10 milligrams per day at week 21 and down to 0 thereafter. Rituximab was given weekly 4 times at 375 milligrams per square meters. Major inclusion criteria was MPA or GPA by the 2012 CHCC definition and positive for MPO or PR3 anchor. Patients with severe renal dysfunction were excluded. The median age of patients was 73 to 74. 3/4 of the patients had MPA and 85% were positive for MPO ANCA. The estimated GFR was 52 to 55 milliliter per minute per 1.73 square meters. CRP was 7.7 to 7.9, and BVAS score was 13 to 15. The primary endpoint was the proportion of patients with remission at month 6. LOVAS was a non-inferiority trial, and it met its primary endpoint. The proportion of patients with remission in the low-dose GC group was non-inferior to that in the high-dose group. There were no significant differences in relapse, death, and end-stage kidney diseases between the two groups. As was expected, the number and proportion of patients with serious adverse events, serious infections, and overall infections were lower in the low-dose GC group compared to the high-dose GC group. The low-dose GC group showed better safety in terms of predefined GC-related adverse events such as dyslipidemia, insomnia, and diabetes mellitus. Another important clinical trial in the last year is ADVOCATE trial, a phase 3 clinical trial comparing C5a receptor antagonist, avacopan, and prednisone. The test group received 30 milligrams twice daily of avacopan and prednisone. The control group received avacopan matching placebo and prednisone starting at 60 milligrams per kg per day. Both groups received rituximab or cyclophosphamide. In the case of cyclophosphamide, azacitidine was used as remission maintenance therapy. The co-primary endpoints were remission at week 26 based on BVAS and sustained remission at week 52. Being GC-free was a prerequisite for achieving remission in the ADVOCATE trial. The proportion of patients achieving remission at week 26 was similar between the two groups, 70% in the control group versus 72% in the avacopan group, and non-inferiority was demonstrated. The proportion of patients with sustained remission at week 52 was 55% for the control group and 66% for the avacopan group. As shown in the right panel, at week 52, non-inferiority as well as superiority of the avacopan group versus the control group were demonstrated. In this ADVOCATE trial, GC toxicity was measured using glucocorticoid toxicity index scores or GTI scores at week 13 and at week 26. Two methods were used to calculate GTI scores, GTI-CWS and GTI-AIS. Both scores were significantly lower in the avacopan group than in the control group. As shown in the slide, the 95 confidence intervals of difference between the two groups did not include 0. In January of this year, safety and efficacy of rituximab for pediatric patients with GPA or MPA were reported. In this trial, 20 patients with MPA or GPA were enrolled. 80% of them were female, and the median age was 14 years old. 68% were white, and 16 were Asian. Majority of the patients had newly diagnosed or relapsed GPA, and a quarter of the patients had MPA. 56% were positive for PR3 anchor, and 32% were positive for MPO anchor. The most frequent adverse event was infusion-related reaction. This AE was observed in 60% of the patients, followed by headache, upper respiratory tract infection, and nausea. The most frequent serious adverse event was GPA worsening, and it was observed in 3 patients, or in 12%. Regarding efficacy, remission based on the pediatric vasculitis activity score (PVAS) was achieved in 56% of the patients at month 6, 92% at month 12, and 100% at month 18. Alemtuzumab, anti-CD52 monoclonal antibody, has been widely used for chronic lymphocytic leukemia and hematopoietic stem cell transplantation. CD52 is expressed on the surface of mature lymphocytes, monocytes, and dendritic cells. This monoclonal antibody was tested for refractory AAV or Behçet's disease. Patients with at least 1 severe or 3 non-severe BVAS items were enrolled. Previous induction therapy for AAV patients should include either cyclophosphamide, methotrexate, or rituximab in combination with prednisolone for at least 3 months. Previous treatment for Behçet's disease should include TNF inhibitors for at least 6 months. Patients were randomly assigned to either low-dose or high-dose alemtuzumab group. The low-dose group received 30 milligrams of alemtuzumab, while high-dose group received 60 milligrams. Oral prednisone was started at 10 milligrams per day and was tapered to 0 by the end of month 4. 23 patients, including 12 AAV and 11 Behçet's disease, were enrolled. Median age was 40.5 years. Male to female ratio was 8:15. 7 were positive for PR3 anchor, 1 was positive for MPO anchor, and 15 were negative for MPO anchor. In the AAV patients, prior median cumulative cyclophosphamide dose was 9.1 grams, and the median cumulative rituximab dose was 4.5 grams, indicating the refractory nature of these patients. Responses to alemtuzumab was reported as follows. At month 6, about 70% of the patients achieved complete or partial remission, and at month 12, more than 40% of the patients achieved complete or partial remission. Let's look at clinical trials for EGPA. Anti-IL-5 receptor alpha monoclonal antibody, benralizumab, has been used for bronchial asthma in many countries. Benralizumab was administered 5 times during 24 weeks in 10 patients with EGPA, and efficacy and safety were analyzed. The mean age of the patients were 47, and half of them were male, 30% were ANCA positive, and all patients had BVAS more than 0. The mean and median prednisone dose was 13.4 milligrams and 15 milligrams per day, respectively. Disease duration of EGPA was 3 years in average. The linear mixed model that accounted for correlation and repeated measures within subjects was employed in this study. The model showed decrease in prednisone dose after treatment with benralizumab. Prednisone dose at pre-treatment phase was 11.6 milligrams. Dose at washing period phase was 13.4 milligrams. Dose at treatment phase was 6.3 milligrams, and dose at post-treatment phase was 5.3 milligrams. As expected, absolute eosinophil counts decreased from 265 at the pre-treatment phase to 0.04 at the washing phase. The low eosinophil count was maintained at the treatment phase and post-treatment phase. Mean annualized exacerbation rate of eGPA was lower during the treatment phase compared to that during the screening and post-treatment phases. Anti-IL-5 monoclonal antibody rheumatolizumab was tested in patients with eGPA. In this trial, 7 doses of rheumatolizumab was given to 10 patients with eGPA. 8 subjects received at least 3 infusions of the test drug and were included in the analysis. Mean prednisone dose was at baseline was 70.5 milligrams per day, and it declined to 8.1 milligrams at week 28. Absolute eosinophil count decreased from 187 to 87, although the difference was not statistically significant. BVAS significantly decreased from 8.2 to 4.2. Okay. Now, let's move on to large vessel vasculitis. 2 classification criteria for large vessel vasculitis have been proposed at ACR Convergence 2021. The first one was the classification criteria for giant cell arteritis, GCA. A diagnosis of large vessel vasculitis should be made before applying this criteria. Absolute requirements for this criteria is age equal or higher than 50 years at the time of diagnosis. This criteria does not have items with negative scores. In the validation set, the sensitivity was 87% and the specificity was 95%. The second one is criteria for Takayasu arthritis. Again, a diagnosis of large vessel vasculitis should be made before applying this criteria. Patients should be equal or younger than 60 years old at the time of diagnosis and should have evidence of large vessel vasculitis on imaging. This criteria also does not have items with negative scores. In the validation set, the sensitivity was 94% and the specificity was 99%. A clinical trial of tocilizumab for Takayasu arthritis, TACT study, has been published, and tocilizumab is recommended as a second-line treatment in the Japanese guidelines for Takayasu arthritis. A pitfall of tocilizumab treatment for Takayasu arthritis is that CRP can be negative during treatment, even if the vascular lesion is progressed. In this paper, results of vascular imaging analysis in 28 patients who received at least 1 dose of tocilizumab and completed 96-week follow-up were reported. The primary endpoint in this post-hoc analysis was the changes from baseline in wall thickness at week 96 assessed for each artery. 22 arteries in 28 patients were analyzed. 84.6% of the arteries had stable wall thickness lesions. 2.1% had improved lesions, whereas 2.4% had partially progressed lesions, and 3.6% had newly progressed lesions at week 96. The proportion of arteries with partially or newly progressed lesions were very small. 0.8% for dilatation or aneurysm, 1.0% for stenosis or occlusion, and 2.6% for wall enhancement. Of the 28 patients who received tocilizumab, improved or stable wall thickness were observed in 29% of the patients each, whereas partial progression in 10.7% and the new progression in 29%. Dilatation or aneurysm was stable in 92.9% of the patients. Stenosis or occlusion were improved or stable in 86%, and wall enhancement was improved or stable in 98.6%. The authors concluded that patients who experienced wall thickness progression should be monitored regularly by imaging, and additional treatment should be considered to avoid vascular progression. NIH investigators developed semi-quantitative and qualitative methods of vascular FDG PET activity measurement in large vessel vasculitis. They analyzed PET CT images from 52 patients with GCA and 43 patients with Takayasu arthritis. In the qualitative method, 4 segments of the aorta and 5 branch arteries were evaluated to assign scores between 0 and 3, representing the visual degree of arterial 18F FDG uptake relative to liver. 0 means no uptake, 1 less than liver, 2 similar to liver, and 3 greater than liver. Adding the territory scores makes a summary score ranging from 0 to 27, which was called PET-VAS. In the semi-quantitative method, 5 segments of aorta and 4 branch arteries in the axial dimension were evaluated. The 18F FDG SUV max per ROI region of interest of each territory was identified. The average of the SUV max of the 9 territories was calculated and named as SUV artery. SUV means in the liver dome and within venous blood pool were calculated. SUV artery was divided by each background SUV mean, generating 2 tissue background ratio metrics or TBR metrics. Those were liver TBR and blood TBR. The left panel shows that semi-quantitative FDG PET assessment scores decreased in patients whose treatment were intensified, whereas the score did not change in patients whose treatment were not changed. The right panel shows changes in qualitative FDG PET assessment scores. The scores decreased in patients who required treatment intensification, but the scores did not change in patients who did not require treatment changes. This brought us to the end of my presentation. I hope you enjoyed my presentations, and thank you very much for your attention.
Thank you, Professor Masayoshi, for an excellent talk on vasculitis. Now we'll begin with live Q&A session. Before starting the Q&A session, I would request all of you to all the participants to click on the link given in the chat box, and so that you can fill the feedback form in order to claim your CME credits and to get your certificate. Now we'll start with questions of each speaker one by one. First, I'll request Professor Eisenberg to answer the questions. There are questions. The first question is, are you there, Professor Eisenberg?
Yeah, I am, but
okay.
There's a message that the host has stopped it.
Okay.
I'm here. Can you hear me?
Yes, we can hear you. You can turn on your video if you want.
Well, I can. There's a message saying you can't turn on your video because the host has stopped it. So I don't quite know what to do.
Okay, we'll check. Okay. The first question is from you, that if a patient has got sign and symptoms of lupus and has got ANA positive, but other serologies are negative and only has anti-thyroid antibodies positive, what can you treat the patient on the lines of lupus?
Well, you treat the patient on the lines of clinical need. You don't treat simply the blood test results. So I think the blood test results act as a warning sign that things may develop. But the fact is that some 20% of the healthy population at different times of its life has anti-nuclear antibodies. The titer is very important. Titer 1 in 40 or 1 in 80 doesn't mean very much. Titer 1 in 5,000 would concern me more. Hang on, let's try this. How's that?
Yes, now we can see you.
So yeah, so the higher the titer, the more you worry. And obviously the presence of anti-thyroid antibodies may also anticipate the development of autoimmune thyroid disease. So I always say you treat the patient, not the number, you watch the number, and it may be relevant in terms of how you're going to manage the patient, but a positive anti-nuclear antibody on its own with anti-thyroid antibodies, I wouldn't treat that.
Okay, thank you. Next, I would like to ask a question from Professor Sumaira, that what is your experience with warfarin and monitoring of INR in lupus patients and APLS patients?
Thank you for your question. Our experience in Pakistan,
yes.
Because of issues of monitoring, availability of labs, and I think quality control, you just struggle and you just do it because although you have rivaroxaban available here, but we do not have actual data. We still need to compute that. But clinically, I think, and Anita would agree with me, all patients of lupus or without, or even those with primary APLS who have come to us with clinical syndrome, a few of them have been put on rivaroxaban by some rheumatologists, and they all came back with major thrombosis, So generally speaking, if we need to anticoagulate, we do use warfarin and not rivaroxaban. And we find that patients will make the effort as long as you can explain it to them, so you know how to monitor the INR, and luckily you have a good family physician practice, or they will WhatsApp now, and so it's a difficult thing, but it is doable. Neha, do you want to add anything?
Thank you so much, David. It was an excellent talk. I agree with you, Sumaira, because we still are, worried about monitoring, but we find that Rox and rivaroxaban is still not a choice for us. I don't know why. We go with warfarin most of the time, but here, David, you did point out that for DVT, which is just not triple positive, you can use rivaroxaban. We have not tried that as yet.
The point that I was making here was that there is a nuance which some of the regulatory authorities at the moment don't seem to recognise. There is a major difference between a patient who has, let's say, 1 or 2 antiphospholipid antibodies and a single deep venous thrombosis, and a patient who is triple positive with arterial problems. I think that's a very different situation. And certainly the data, and this data from the original RAP study shows very clearly, I think, that you can treat patients who've had a DVT in the context of APS with single or double positive antiphospholipid antibodies very safely with rivaroxaban, and we certainly do that as a routine. I mentioned the RISAPS trial. We're now on the point of fulfilling the numbers of patients that we needed for the phase 2 trial, which is 40. We've got about 38 as I speak, so we're hoping to recruit 2 more this week to fill that. And that's looking at patients who've had arterial events with a single or double positive expression of APS, antibodies, positive antibodies. But we do recognise that triple positive makes you, that's certainly a much higher risk, and I agree, I would certainly manage those patients with warfarin.
Okay. So, David, you are suggesting that we should go with rivaroxaban in patients who have venous thrombosis, and yes. So how long would you continue? You know, if it is a major organ like, you know, somewhere in a big artery, venous, then you continue for the rest of the life. But with a DVT, for example, in the leg, do you continue for 9 months or a year, or how long would you continue?
Well, that certainly is a question which I have discussed with our hematologists on many occasions and have received slightly different answers on several occasions. I would say most people would probably go for a minimum of 3 to 6. Some have said at least a year. 1 or 2 have said lifelong if it's antiphospholipid antibody syndrome. So I'm very good. You have to discuss this with your local hematologist, I think. I looked at David Cruz must have pretty good experience. Let's just say what you'll do.
Yes, thank you very much, David. Very, very enlightening talk. And so there's another nuance, I think. Patients with venous thrombosis, but recurrent venous thrombosis, even if they're single or double positive, I would probably use warfarin if they've got recurrent thrombosis. But again, the jury's out here, because the RAP study, you included patients who had a single thrombosis, not multiple, and were on warfarin. So I think the jury's still out here. I don't think I would use a DOAC for patients with recurrent venous thromboses, because they tend to be the high-risk patients. And I'd probably switch them from a DOAC to warfarin. So what are your thoughts on that?
Well, yeah, I think that's an unanswered question, really, and it is a concern. And clearly, one always wants to do the best for the patient, but as I think we all agree, warfarin is not a simple option for patients. It's very restrictive in terms of diet, in terms of other drugs, in terms of monitoring on a regular basis. The beauty of the DOACs is that they don't require these restrictions and they don't require the regular monitoring. But equally, you're right. You know, if you've got a patient with who's had half a dozen deep venous thromboses, you probably would put warfarin. I agree.
David, what I feel is that in our country, as you know, testing for antiphospholipid antibodies, all 3 of them, is very costly. So when somebody comes in with a DVT and does not, and we know that, you know, it's got lupus or was APLS, whatever, we cannot spend like so much money sometimes to investigate them. So not knowing that are they double positive, are they triple positive, so that's why we are a little apprehensive of starting them on rivaroxaban.
No, I do understand that. Although I would also point out that 27% of the patients in the the RAPS trial, that's the trial with the venous thrombosis, those patients were triple positive, and they did just as well on DOACs as they did on warfarin.
Okay. So,
thank you.
Right.
So,
I think slowly we should, be brave enough to do so.
okay.
Can I ask a question from David? Hi, David. David De Cruz. And hi, David. Professor Eisenberg, I say Professor Eisenberg, because, this is a fan moment for me. We've come to your 10 topics, and David is David, because he's a friend as well, so I'm taking that liberty. So, David, I just wanted to know, you mentioned about a neuropsychiatric lupus and using PET scan, and I just, the concept that I generally had is that PET is not really good for cerebral vasculitis. So
I think that's right, Samira. I think that's right. So the people who use PET scanning in neurological disease are our neurologists. Paul Holmes is our neurologist I work with, and he often uses PET scanning in these neurological syndromes. And I asked Paul, what do these scans mean? He said, I'm not sure. The jury's out. So I think there's a way to go to interpreting PET scanning in neurological diseases. The example I showed you was we were a bit concerned about malignancy. That's why we did the PET scan in that patient.
So there's another question from Professor Eisenberg, that if a young patient with lupus having a history of multiple first trimester abortions comes to you and she is not pregnant, would you like to give aspirin to her?
I'm sorry, I missed the problem. She said what?
A young female with lupus and history of multiple abortions, and currently she is not pregnant. Would you give her aspirin?
I think the role of aspirin, again, a mutual colleague was trying to, was trying to resolve the question of aspirin some years ago, as David Cruz worked very well. And this was a very ambitious trial where we were aiming to recruit 1,000 patients. When we only got up to 100 after about 4 years, we had to abandon the trial. But again, it's a question which is dogged by a lack of real hard data, on the sense that an aspirin is unlikely to do any significant harm, and there's some suggestion it's quite good in lupus patients. I wouldn't have a particular problem in prescribing it, although is it really going to affect the patient's capacity to get pregnant? Well, that's another story, as in fact it's Thomas's group which actually highlighted a number of years ago, the combination of heparin and aspirin being the better way to go.
Okay, thank you. Thank you. Now there's a question from Professor David De Cruz, for Professor David De Cruz, that how can you manage a patient who has cerebral lupus plus tuberculosis, and is there any role of IV immunoglobulins in such cases? Because we see tuberculosis.
So that's exactly what we did. So that patient I told you about briefly had classic cerebral lupus and cerebral TB. We used IVIG first. So modest dose of steroids, intravenous immunoglobulins, and when her disease was improving from the tuberculosis point of view, and we were controlling all the other factors. I mean, this was a really challenging case. We had the infectious diseases team, the neurologist, and everybody involved. We then switched over to immunosuppression once we were fairly sure that the TB was under control. So a very scary situation, but she's done well, in fact. Yeah, but IVIG definitely has a role here.
Okay, thank you. Now I would like to ask Professor Sumaira and Professor Nigar about their experience in using IVIG in lupus patients in Pakistan.
We've had very good experience in the setting of infection, particularly, and because in Pakistan, infections are the first top thing that you need to rule out for any patient, lupus or otherwise, when they come in with history of fever, So, and it's very, very difficult, and endemic tuberculosis and all. So if there is any, if it is, you obviously go and you treat, you do review for the infections and you treat as much as possible whatever underlying infection there is. The one thing that you can give for lupus flare, which is usually there also at the same time, is basically IVIG in that setting. And I think the limiting thing for us is the cost. Otherwise, we've had very, very good results from using IVIG. Nikhil?
Thank you.
Yes, I agree with you, Sumaira. In our situation, it works very well. I have two questions though, because whenever we see active lupus and infections, and we have patients on IVIG, and now we want to give, rituximab. So there is our infectious disease people have different view, and we have different view. They want to wait at least for 4 weeks, after we use rituximab after giving IVIG. While as David, you said that. What is your view on that? Because IVIG is great, Sumaira. You know that it works very well in our setting, except of course the cost. And our foundation helps most of the needy people also with the cost of IVIG. So what are your thoughts about the interval between the two?
For IVIG and lupus, Nigar?
And rituximab, because you have controlled infection, and now you want to put them back on treatment. For example, you have patients who need to be right away on therapy, which lupus.
So our approach is very similar to yours. We would use IVIG, and when the infections come under control, we would then move on to rituximab. Our rituximab protocol has been modified by COVID, I'm afraid. We're using less and less rituximab because all the studies now suggest that rituximab is a powerful predictor of developing serious COVID. And as you probably heard in the UK, COVID numbers are rising. It's perhaps not as dangerous as the Delta variant, but we're very, very cautious now using rituximab. We have a few patients with lupus who we are treating with the antivasculitis protocols. In other words, 2 grams of rituximab up front when infection's gone away, and then a gram of rituximab 6 monthly for up to 2 years. But again, very, very, very cautiously in the era of COVID. And we always encourage patients to be fully vaccinated before starting rituximab. We have our fair share of vaccine hesitancy. Those are really, really quite tricky. And I make them sign written consent forms to say, you're not vaccinated, you want rituximab, there is a risk of dying or serious mortality or morbidity. The patients sign. So far, we've not had a disaster. But yeah, we need to be very careful.
Okay, great. Thank you so much. Thanks a lot.
There's another question that have you used IVIG in patients with cerebral lupus? If yes, what response have you seen?
Yeah. So one of the problems is that IVIG is very, very strictly regulated. We have to approach a panel to use IVIG in any of our patients. It's not approved. And if it is approved, we have to pay for it out of our department budget. So we've not used IVIG as much as we used to for that reason. I've not used IVIG in patients with cerebral lupus. I tend to go with immunosuppression first off, unless, of course, they've got infection, in which case one would make a case for IVIG.
Okay,
in that small circumstance.
Yes, thank you. The next question is from Professor De Cruz, that how common is acute psychosis in neuropsychiatric lupus, and will these patients need extra immunosuppression if the lupus is otherwise stable?
So this is a very, very challenging area. So Graham Hughes taught me that, and I recognize this as a truth, he's seen, and I've seen a number of patients with pure discoid lupus and florid neuropsychiatric lupus. And we treat those patients as if they've got SLE with neuropsychiatric disease in the usual way with immunosuppression. So yes, it is possible to have neuropsychiatric lupus with little or no extra cerebral manifestations, as it were. Okay. And I just treat them in the conventional way.
Thank you. The next question is from Professor De Cruz, that if a lupus patient has seizures and cerebritis, what would be the duration of use of anticonvulsants? For how long you use them?
I always defer to my neurologist. So we've seen lupus patients with a single seizure in the context of very, very active disease. They would be put on anticonvulsants. And after 6 months or a year, if they've not had any more seizures, I will have a discussion with the neurologist about tapering and stopping the anticonvulsants. But it's not my decision. I make the decision with the patient and definitely with the neurologist's recommendations. And background and EEG as well.
Thank you. Thank you.
Because obviously if the EEG shows residual seizure activity, I would not be stopping anticonvulsant therapy.
Okay, thank you. Thank you, Professor De Cruz. Now, we have a few questions for Professor Lai Shan Tam. The first question is that would you label a 37 years old female who presented with a variable history, a history of variable back pain and with normal MRI of the sacroiliac joints, but with positive HLA-B27? What would you label that patient? How you will go about that?
Thank you very much. I think diagnosis of axial spondyloarthritis always is problematic. We go with the ASAS criteria, but this is not a diagnostic criteria. So I think clinical parameters, how the patient presents, whether the patient has inflammatory back pain, whether she has any comorbidities like uveitis, psoriasis, family history of spondyloarthritis, and the measurement of the ESR and CRP. We just have to take everything into consideration, before we label whether this patient has just fulfilling the clinical arm of the ASAS criteria. But I think most of these patients actually needs follow-up and follow-up imaging if necessary.
Thank you. Thank you.
I think the question that the person wants to have answered is, Lashan, that can you have SPA and not have sacroiliitis on MR at that point in time?
Definitely. So that's why I think if the clinical scenario, if the patient has severe back pain, inflammatory back pain, has family history of axial spondyloarthritis, raised inflammatory markers, and so on, definitely we need to follow this patient. And normally we would consider repeating an MRI in 9 months to a year.
Okay. Now, we have a question from Professor Sumaira and Professor Nigar, that are we using HRPQCT in Pakistan? Excuse me.
I don't know if it is even available, and I've never used it. I don't think it's available as yet, unfortunately. So, and
yes, we don't have it, Laishan.
We don't have it.
Okay, so you know, this is a very useful machine, and very small, and with the extreme CT tool, you can even you know, image the elbow and the knee joint. So it would be very good to look at you know, other joints as well. But you know, we are having we understand that actually only maybe 30 machines are available around the world, so it's still pretty restricted, we understand, but this machine definitely has a lot of potential. So please come over and visit our center, and I will show you.
Thank you, thank you. Thank you for answering.
Love to do that.
The next question from Professor Laishan Tam is that how can we differentiate between newborn formation in psoriatic arthritis from the newborn formation of nodal osteoarthritis?
Osteoarthritis, okay. So again, this is a very good question. So, you know, especially when we are looking at the DIP joints in patients, you know, with psoriasis, so we always wonder whether this is, you know, the DIP involvement of psoriatic arthritis, or is that osteoarthritis, for example, if they are, you know, in their 50s. So we understand that newborn formation in psoriatic arthritis is a result of enthesopathy. So is, you know, the newborn formation should be at the site of the enthesis. Whereas in patients with osteoarthritis, the osteophytes are usually found along the joint line. So using this high resolution imaging machine, we can, you know, clearly demarcate where the new bone is. So it really helps us a lot in differentiating, you know, which patient has what.
Thank you. Thank you. Now there are few questions.
Is it possible to have both? I mean, with long-standing psoriatic arthritis, yeah, you can have.
Oh yes, but we tend to see a lot of these enthesiophytes in patients with psoriatic disease.
Yeah.
Whereas you know, in rheumatoid, we seldom see these newborn formation. So it's also helpful for us to differentiate whether this is rheumatoid or psoriatic arthritis if you're seeing symmetrical polyarthritis seronegative.
Can I ask a question? I think, Dash, and it was a brilliant talk, but you know, clinically we face so much dilemma, especially in our situation where we cannot get MRIs on everybody. But if somebody has inflammatory back pain, clear cut, and we have no doubts about that, and they have somebody in the family who has psoriasis, and we don't have HLA-B27, and we don't have MRI, and the patient, you know, responds to NSAIDs, but cannot take long-term NSAIDs, can you ever decide in such a patient to use biologics? Just on that basis?
Again, very good questions. So nowadays we understand the limitations of X-ray of the SI joint, because even in expert hands, the you know, the concordance rate of diagnosing sacroiliitis on X-ray is still very low. So we are moving actually towards using low-dose CT of the sacroiliac joint, which can really help a lot to clarify whether the patient has sclerosis, erosions, and joint space narrowing. So actually, you know, we are now, I think we should move on to actually replace radiography by low-dose CT, because we have been doing this in our unit, and the radiation exposure is like 27 millisievert. So it's actually similar to an X-ray of the spine, which is 25 millisievert. But the information that we can get is much better. So we would highly recommend to consider performing low-dose CT of the SI joint. If, like us, we have also some problem accessing MRI. So low-dose CT of the SI joint would be a very good alternative.
Excellent, that's great, because we can do that and that's easily available.
Yes. Yeah.
Thank you. Thank you. Thank you. Now we have a few questions from Professor Jawad. For Professor Jawad, first question is that how can we differentiate between tuberculoma from sarcoid lesion tuberculoma from sarcoid lesion? How can we differentiate tuberculoma from sarcoid lesion on MRI?
Hello?
Yes, yes, we can hear you.
You can hear me?
Yeah.
Well, I think you have to do an IGRA test, I think, if possible. And you could see really in a way, you saw the imaging of sarcoid. It's quite distinctive. And it's really very rare that you will see a lesion that is similar to a tuberculoma, because it's the cerebral, the actual lesions within the brain, as you can see, are usually associated with leptomeningitis, and they are really quite distinctive. And in fact, the imaging is quite diagnostic for radiologists who have seen so many. But doing an IGRA test will be very useful. And obviously, if there is a tuberculoma, I think higher resolution CT scan of the lungs to make sure there are no other lesions.
Thank you. Thank you. The next question is that how far you want to investigate someone who has uveitis or a facial palsy in order to rule out sarcoid? How far you want to investigate?
Uveitis, you have to leave it to the ophthalmic surgeons, to the ophthalmologist. I mean, most patients with anterior uveitis, it's unilateral, and there's nothing to suggest that the patient is unwell. Generally, is treated with local treatment, but a good history if you take a good history from the patient, a general examination should really suffice. But if the patient has anterior or intermediate uveitis or panuveitis, then I think panuveitis should be investigated. If it's bilateral, it should always be investigated. And if it is recurrent, it should be investigated. Generally, facial palsy is very common again, and most cases are really labeled as Bell's palsy. I think in a way, if you are suspicious, then a 5-day course of prednisolone, if it is sarcoid, it will clear very quickly. Sarcoidosis is very sensitive to steroids, more sensitive than lupus and vasculitis. You could say rheumatoid is also very sensitive to steroids. So 30 milligrams of prednisolone for 5 days should really be enough.
Thank you. Thank you, Professor Jawad, for a detailed answer. The next question from you is that is there any association between brain and spinal cord involvement with lung involvement in sarcoid? Is there any association between the two?
No, generally, spinal cord involvement is extremely rare, and most of the patients that have spinal cord involvement, usually they have sarcoidosis elsewhere, pulmonary. It's very rare. The only type of sarcoid that could present really as first presentation without associated symptoms, usually facial nerve palsy. It's very rare for sarcoidosis of the brain and the spinal cord not to be associated with sarcoid elsewhere.
Okay, thank you. And the last question from you is that are there any CT and MRI brain findings that distinguish between neurosarcoid, neurosjogren's, lupus, and multiple sclerosis or CNS vasculitis?
Yeah. Well, as you saw from the main feature radiologically is in fact the meningeal involvement, and you saw it's really quite distinctive. And while, for example, in MS, it's mainly parenchymal disease, and we saw even in lupus, and in the majority of patients with lupus, it is parenchymal disease that is, or it is due to APS rather than vasculitic in nature. I think vasculitis as a cause of neurological symptoms in patients with rheumatic disease is really very rare. Think of parenchymal involvement. Very similar. What you see in Sjogren and lupus is very similar to demyelinating disease, which you don't really see that clearly in patients with sarcoid. With sarcoid, it's always beaded, it's interrupted, and it's quite as you saw, the pachymeningeal and the leptomeningeal involvement is very distinctive.
Okay, thank you. Thank you. Thank you, Professor Jawad, for a detailed answer. Now we'll move on to questions that have been asked from Professor Masayoshi. The first question is that how is there any role of plasmapheresis in patients with aggressive GPA or eGPA?
Yes, thank you for your question. Yes, there is. There is a place for plasmapheresis in patients with severe cases with GPA or MPA, and especially the clinical trial shows that there is no advantage in the use of plasmapheresis, but meta-analysis and some other studies shows that if there is severe case of MPA GPA, plasmapheresis may prevent progression of renal disease and will help to avoid renal death in such patients.
Thank you. The next question is from you is, what do you suggest is the best modality helpful for vasculitis, MRA or PET scan?
You mean a large vessel vasculitis?
Yes, yes.
Both modalities do work, but in Japan, we usually use MRI or CT for first analysis, and if we cannot get appropriate answer or judgment from such modalities, we go to FDG PET. And as you know, FDG radioactivity is very high when we use FDG PET, and many patients with Takayama arthritis is a young female, so we try to avoid using FDG PET as much as possible.
Thank you. The next question is that is there any role of sural nerve biopsy in patients with vasculitis, especially eGPA, for the diagnosis?
Yes, there is a room for peripheral nerve biopsy, but currently we seldom do that, and patients do not want to be performed peripheral nerve biopsy if we explain them that they will have residual numbness in the lower foot.
Okay. Thank you. And the last question from you is that there is a question that I have seen a lady with recurring big bruises, mildly raised ESR, and without any symptoms, but PR3 is positive. Do you think that she can have vasculitis, or the vasculitis should be in the differentials?
Sorry, I couldn't catch the first part.
A lady with recurring bruises, mildly raised ESR and CRP, and PR3 is positive. Would you consider vasculitis?
Yes, she may have AAV, but maybe I will put her under observation and urges her revisit our clinic every 2 or 3 months.
Professor Harigai, I wanted to ask you a question. You mentioned about the trial in childhood vasculitis, and you mentioned that rituximab, unfortunately, there was a flare-up in 3 patients. Was there any, those patients, do they have any particular, reason for it? Could you identify why they had it? I mean, was there a factor that you could identify that caused them to trigger?
for that question, I do not have an appropriate answer. Sorry.
No, that's fine. I was just wondering, maybe.
Yeah.
So,
thank you. Now, as a question, we have almost answered a lot of the questions from the Q&A. I would request Professor Sumaira for her closing remarks of the session.
Okay.
Over to you, ma'am.
So, I'm just going to go speaker first. So, thank you so much, Laishan, for being a part of this course. It's such a pleasure and privilege. And just to let everyone know what a dynamic figure she is, how much she has done for rheumatology in the Asia-Pacific region, facilitated exchange of young rheumatologists going to ULAR and back. I mean, it's an amazing thing and she is convening the Hong Kong conference, and good luck to you, and thank you so much for being a part of this. Look forward to seeing you there. Thank you.
Thank you very much for inviting me. I really look forward to seeing all of you in Hong Kong next month. In December, sorry.
Oh, yeah. Okay, from there, I'm moving on to Professor Eisenberg. I did mention that this is a fan moment for me because especially Saira and myself, Saira, who's the convener, both of us actually especially made a trip to attend 10 topics at St. Thomas's. And David, you remember, we were there, and it cost us a pretty penny to do it, So how wonderful to have had your generous expertise shared with all of us, and across the board. It has been such a wonderful experience. And thank you from all of us at PSR on behalf of Saira and Bilal and the scientific committee. It's wonderful to. Hopefully, we will be meeting next time here in Pakistan too.
Thank you for your very generous and very kind words. I look forward to further meetings.
Yes. And okay, now David. What can I say about David? David has been a true friend of PSR of Pakistan. He has come here for our conferences when nobody else was coming, just David and Terry. I think they were our star speakers for many events, and he's like family to us. What a great, he's such a great clinician, researcher, and such a well-known person in the world of rheumatology. I think PSR primarily used to run on your presentations, David. So thank you. We missed you this time, but from all of us, thank you ever so much for always being this generous in giving us your time and expertise.
Thank you so much, Sumaira, Nigit, and Sarah. I always enjoy coming to Pakistan. It's a fantastic place. I'm just sorry in the last few years I've not been able to make it, but it's always good fun. You always treat me very, very well in terms of hospitality. Thank you again for all the invitations.
No, it's always a pleasure. And Professor Ali Jawad, again, such a dear friend. He's come to Pakistan. He has done so much through the Royal College of Physicians for, promoting education amongst the developing countries in our region. We have a lot of problems for our trainees, and he has been instrumental in, making room and giving opportunities to them. So I just want to again say thank you, Ali, for always responding to our invitations and being part of any academic activity that we do. Very, very kind of you to do that. I don't know if he's here or not. So,
yeah,
and
he's
lastly, but not the least, Professor Harigai, you represent the best of APLA. I don't know if everybody would know what a great researcher you are, how much work you've done in the field that you are representing, taking time out and share your expertise with us. We are truly honored.
Thank you very much, your kind words. I wanted to visit you this time, but unfortunately I couldn't. So next time.
I think I hope this whole group can meet next time. That would be so nice. Yes?
That would be fantastic.
Yes. So now we're going to shift to the second part where Nighat is going to be chairing, and I'm handing over now to Bilal and Saira. And bye-bye from me.
Thank you. It was really an honor. Please fill in your feedback forms, and we'll be back in about 10 minutes for the next session. 10 to 15 minutes for the next session. Thank you.
Thank you.
And see you again after 15 minutes.
Yeah, David loves your sweater. Thank you, Professor. Thank you.
Thank you.
Okay. Bye-bye.
Bye-bye.
Thank you. Thank you so much.
Bye. Take care. Thank you so much.
Yes. Thank you.